on. Can you hear me? Good evening all. Can you all hear me? Hi Pooja, Mulai Vendan. Can you hear me? Okay. So you can all hear me, I suppose. Hi Anwar, Bhavin. Okay, welcome to the session. So session is and which are likely to come for the upcoming FMGE exam. So I have few things about anatomy here. Anatomy, something about amniotic fluid, antenatal care, antepartum fetal surveillance. Okay, and we also have few important questions from vaccination in pregnancy, gestational trophoblastic diseases, fibroid and hypertension complicating pregnancy. Okay, so these are the topics of interest for today. Since this is a rapid revision kind of thing, I want you all to just focus and listen and take as many points as possible home. Do not try to write anything because this is going to be available. This session is going to be available in the YouTube for the next few days. So you can always go back and watch later. For any of your doubts, you can ask me now. Otherwise, don't waste your time in writing anything. Okay. Voice is not good. Is there a lag? Is it clear now? Hi Mulai Vendan. Can you hear me now? Okay. Okay, fine. Okay, let me start the session. The first question is here. The first question, I have picked few questions from your previous FMGE paper. Okay. So this question again was a question from the previous FMGE paper. The question is fallopian tube is lined by. Fallopian tube is lined by. What's your answer, guys? Come on, give your answer. Fallopian tube is lined by. Yes? Is lined by. I think most of you are clear now. Fallopian tube is lined by columnar epithelium. Okay. So is it ciliated columnar or non-ciliated columnar? Yes, it is ciliated columnar. Okay. So quickly we will revise the points under this topic. So what is the lining epithelium of the vagina and the ectocervix? Vagina and the ectocervix, what is it lined by? Yes? Non-keratinized, stratified epithelium. Non-keratinized, stratified squamous epithelium. Yes? Voice is breaking even now. Okay. Just a minute, guys. Let me sort this out. Voice is breaking. Okay, guys, just hold on. Saidul is calling. Sir. Guys, can you hear me now? Can you hear me now? Okay, let me begin. Okay, that's good. Right. Okay. Are non-recognized stratified squamous epithelium. Now coming to the endocervix and endometrium. Tell me guys, what is it lined by? Endocervix and endometrium. What are they lined by? Yes. Columnar, right? Yes. Is it ciliated columnar or non-ciliated columnar? Yes, it is lined by mixed, ciliated, non-ciliated columnar epithelium. It is lined by mixed, ciliated, non-ciliated columnar epithelium. Okay. And your fallopian tubes are lined by ciliated columnar epithelium. Fallopian tubes are lined by ciliated columnar epithelium. Right. Now, what pacemaker cells in the fallopian tube otherwise called as? Pacemaker cells. Okay, so whenever you asked voice is clear, only that time voice. Okay, Akash, I'm sorry for that. Okay, now try to follow. Where do we have pacemaker cells? Tell me, where do we have pacemaker cells in the genital tract? Is it in the cervix or the uterus or the fallopian tube? Where are they present? Yes? Pacemaker cells are present in the... Okay. Pacemaker cells are present in the fallopian tube. Okay. Pacemaker cells are present in the fallopian tube. Okay. Now tell me, what are these pacemaker cells otherwise called as? Yes. What are these pacemaker cells otherwise called as? Again, voice is not clear. Okay. Okay, guys, can you hear me now? Guys, can you hear me now? Okay. So, what are these pacemaker cells otherwise called as? I'm just asking you where these pacemaker cells are present. Yes, in the genital tract, you have pacemaker cells which initiate the contractions, right? So, where are these pacemaker cells present? I'm asking. Yes? Fine. Where are these pacemaker cells present? Yes, you have pacemaker cells in the fallopian tube, in the uterus as well. You have pacemaker cells in the uterus. But these pacemaker cells, like heart, are not located to one particular part of the uterus. Rather, they are scattered over the uterus. Okay, these pacemaker cells are scattered all over the uterus. You all understand? Okay. And they're also present in the fallopian tube. Now, the most important MCQ is what are these pacemaker cells called as? You have another name for these pacemaker cells. Yes, these pacemaker cells are called interstitial cells of Kajal. Okay, the pacemaker cells in the fallopian tube are called interstitial cells of Kajal. Okay, pacemaker cells in the fallopian tube are called interstitial cells of Kajal. Okay, so I think you can hear me now, Tarun and Farhan. I think you can hear me now. Okay. Interstitial okay now? Okay. I think it should be better now. Let us continue, guys. Cells, what are these pacemaker cells otherwise called as? These pacemaker cells are otherwise called as interstitial cells of Kajal, and that was what I was trying to tell you. Okay. Now, there's another important question from this what are the specialized cells that are present in the fallopian tube called as? One specialized cell is present in the fallopian tube amidst the epithelium and the pacemaker cells. What is it called as? Yes, we have one important specialized cell in the fallopian tube, the function of which is not yet known, and yes, they're called as PEG cells. Okay, they're called as PEG cells. Okay, PEG cells. So, are you clear? Yes. So, this is it. The vagina and the ectocervix are lined by non-keratinized stratified squamous epithelium. Endocervix and the endometrium are lined by mixed ciliated, non-ciliated columnar epithelium. The fallopian tube is lined by ciliated columnar epithelium. Pacemaker cells are otherwise called as interstitial cells of Kajal, and PEG cells are specialized cells that are present in the fallopian tube. Okay, specialized cells present in the fallopian tube. Okay, hope you all can hear me now. Yes. In the recent INI-CT exam, we had one MCQ from pain during labor. Pain during labor. Pain during labor. Okay. Now, you all know we have two stages in labor, right? Yes. Two important stages in labor. Totally, there are 4 stages. Stage 1 and stage 2 of labor. So, stage 3 and stage 4 of labor are usually not associated with much pain. You have much pain only in stage 1 and 2, right? Okay. So, where does pain during stage 1 arise from? Is it from the upper genital tract or the lower genital tract? Yes. Guys, I'm asking you, pain during stage 1 of labor, pain during stage 1 of labor, where does it begin from? Is it from the upper genital tract or the lower genital tract? See, listen, pain during the first stage of labor is usually from the upper genital tract, and that is from the uterus. Okay, that is from the uterus. It is due to the uterine contractions. It is due to the uterine contractions. Okay, whereas pain due to, yes, pain due to, pain during the second stage of labor is usually due to the distension of the vagina. Distension of the vagina. So, this is from the lower genital tract. Okay. So, what is the spinal segment through which pain is carried during the first stage of labor? Yes, that is the question here. Okay. So, Yashwant, Pradyuma, Dushyant, yes, you're all correct. So, during stage 1, pain is from the upper genital tract, and that is from the uterus. Okay, it is due to uterine contractions, and it is carried by T10 fibers, mostly T10 to L1. Okay, T10. Whereas during the second stage of labor, it is mainly due to the distension of the vagina. It is due to the distension of the vagina. Okay. So, now is epidural analgesia. Okay, epidural analgesia. Epidural analgesia relieves pain. Epidural analgesia give this thing, no, to block T10 to L1. Okay, which pain does it mainly address? Which pain does it mainly address? Does it address the pain during stage 1 or stage 2? Which pain does it mainly address? Epidural analgesia. Yes? Epidural analgesia mainly addresses pain during stage 1 of labor. Okay, epidural analgesia mainly addresses the pain during stage 1 of labor. Okay. Pain, which segment will you pick? One important spinal segment for the uterine pain. Which one will you pick? Yes, you will pick T10. Most important spinal segment, very important MCQ. Very important MCQ. The most important spinal segment that carries pain during labor is T10. Okay, the most important segment that carries pain during the first labor is T10. Okay, T10. Okay. Hi Williams, can't hear again. My God, I don't know. Okay. So let's move on to the next question here. So what is the answer for this question? Fallopian tube is lined by columnar epithelium. Okay. Fallopian tube is lined by columnar epithelium. Okay, fine. Next we have one important question from the antenatal care. Antenatal care. Okay, the question is here. What is the minimum number of antenatal visits as per the recent WHO guideline? The minimum number of antenatal visit as per the recent WHO guideline. Alia, your answer is for the first or the second question? Yes? The minimum number of antenatal visit as per the recent WHO guideline. Most common wrong answer is 4. The correct answer is 8. Oh, 4 visit, Aditya, Pooja, 4 visit is wrong, Kana. 4 visit is wrong. 8 is the correct answer. The minimum number of antenatal visit as per the recent WHO guideline is 8 visit. 8 visits. Okay. So let me give you more information on that. Okay. Now remember, regarding the number of antenatal visits, we have 2 important guidelines from the WHO. Okay, so the WHO until 2015 recommended 4 antenatal visits. Okay, 4 antenatal visits until 2016. Okay, the revised 2016 WHO guideline recommends minimum 8 antenatal visits. Okay, it recommends 8 antenatal visits. Okay, yes, it has changed. Yes, it has changed. Okay, 8 antenatal visits. Sorry, Mahendran. So this question was there in the last FMGE exam. Yes, you had this question in the last FMGE exam. So if it is going to be 8 visits, how will you? Just look at the chart here. Okay, so in the first trimester, okay, in the first trimester there should be one visit within the first 12 weeks of pregnancy. In the second trimester there are supposed to be 2 visits, one at 20 weeks and the other one at 26 weeks. Okay, other one at 26 weeks. And in the third trimester, you will have the remaining 5 visits, one at 30 weeks, and the next at 34, the next at 36, the next at 38, and last at 40 weeks. Okay? So altogether, you must make 8 antenatal visits. Okay. Okay. Okay, Aditya, since you are repeatedly asking this, let me tell you, according to the Ministry of Health and Family Welfare, okay, according to the Ministry of Health and Family Welfare, that means according to our Indian guidelines, the answer is still 4 visit. Okay, the answer is still 4 visit. Okay, but remember the question specifically says WHO. The question specifically says WHO, okay. So, according to WHO, it is 8 visits. So, in case this word WHO is not there, then your answer would be 4, because in our country it is still 4. But the examiner has specifically asked for the recent WHO guideline, okay. The examiner has specifically asked for the recent WHO guideline, and according to the recent WHO guideline, the answer is 8 visit, okay. The answer is 8 visit. Okay. So, this is it. Next important MCQ area is about the prophylactic iron therapy during pregnancy. Okay. Prophylactic iron therapy during pregnancy. Okay. Now, tell me Aditya, Manoj and Mahendran. Okay. Tell me, how much should we give? Prophylactic iron, how much are you going to give? Prophylactic iron during pregnancy. Okay, what do you say? Prophylactic, how much of iron should be given to a normal pregnant woman to prevent dilutional anemia during pregnancy? What is the dose of prophylactic iron? Yes? 60 milligram. Aditya, any other? 60. Elemental iron, 60. Okay, there are 2 different answers for this question. Yes, the WHO recommends, okay, listen, WHO recommends elemental iron 60 milligram, elemental iron 60 milligram starting from the first visit, okay, starting from the first visit, and this should at least be given for 6 months during pregnancy and for 3 months postpartum, okay. But the Government of India, that is the Ministry of Health and Family Welfare, recommends 100 milligram of elemental iron, 100 milligram of elemental iron with 500 microgram of folic acid, whereas the WHO recommends 60 milligram of elemental iron with 400 microgram of folic acid. You all understand? Yes. So, the Ministry of Health and Family Welfare recommends starting iron therapy at 14 weeks, okay, 14 weeks, whereas the WHO recommends starting iron therapy from the first visit, okay, from the booking visit, okay. So, your answer will depend on whether this word WHO is present in the given question. You all understand? Please choose the answer wisely, okay. Please look for the word WHO in the given question, and if that word WHO is there, I'll tell you Aditya, don't worry. If this word WHO is there, then only you go for this answer 60, okay. If this word WHO is there, then only you go for this answer 60, or else for our FMGE exam, and for our NEET PG exam, the answer will always be 100 milligram unless you see the word WHO. You understand? If only the examiner is specifically asking for WHO, guideline, you go 100 milligram of elemental iron. You understand now, Aditya? Yes. So, please remember, what is available in our government institutions. Okay, what is available, what we're giving to our antenatal patients in our government institution is this 335 milligram of ferrous salt with 100 milligram of elemental iron and 500 microgram of folic acid. This is what we distribute in our government hospital. So your answer for our FMGE exam and NEET PG will be 100 milligram. Is it okay? Okay, fine. So now coming to folic acid, okay, there was one question last NEET FMGE exam asking for therapeutic dose of folic acid, okay, asking for the therapeutic dose of folic acid, okay. So what is your answer for that? Therapeutic dose of folic acid. What is the answer for this? Ideal dose of folic acid for women with previous history of neural tube defect. Yes? Ideal dose of folic acid for women with previous history of neural tube defect. What is your answer? What is your answer for this? Okay, so we all know the prophylactic dose of folic acid according to WHO guideline. The prophylactic dose of folic acid according to the WHO guideline is 400 microgram. 400 microgram, which is the same as 0.4 milligram. Yes, which is the same as 0.4 milligram. What is the dose of folic acid for women with previous history of neural tube defect? Answer is not 5 milligram. Manoj, the correct answer is 4 milligram. Most common wrong answer is 5 milligram. Okay? Yes, right. Most common wrong answer is 5 milligram. Okay? Fine. Now, having discussed this, we'll also discuss the indications for therapeutic dose of folic acid. What are the indications for therapeutic dose of folic acid? What are the indications for therapeutic dose of folic acid that okay. Yes, we have 5 indications here. They are number 1, previous history of neural tube defect. Previous history of neural tube defect is the most important indication for therapeutic dose. Next comes megaloblastic anemia. Okay, megaloblastic anemia is the second indication. Next comes hemolytic anemia. Hemolytic anemia during pregnancy is another indication for high dose folic acid. Okay, high dose folic acid. Okay, the next important indication is overt diabetes. Okay, overt diabetes is the next indication. Okay? And last but not the least, women on anti-epileptic therapy. Women on anti-epileptic drugs. Women on anti-epileptic drug is the last indication for therapeutic dose. What are the indications for therapeutic dose or high dose folic acid? Previous history of neural tube defect, megaloblastic anemia, hemolytic anemia, overt diabetes, and women on anti-epileptic therapy. Okay, so these are the indications for high dose folic acid or therapeutic dose of folic acid. Okay, so you all understand now? Yes? Okay. Vaccination during pregnancy. Okay, the next question is on vaccination during pregnancy. Okay, all of you will see this. All of you will see this question. Voice and video lagging. Okay. Okay guys, let me take a break of 2 minutes and sort this problem out. Okay, I'll meet you after 2 or 3 minutes. Please stay. Please stay. Stay back, all of you. Okay. So I think now you can hear me. Okay, look at this question. A pregnant woman at 12 weeks gestation is bitten by a rabid dog. What is the ideal next step? What is the ideal next step? Okay, there were 4 options. Only vaccine, only immunoglobulin, wound care, vaccine plus immunoglobulin. Yes? What is the correct answer here? What is the correct answer here? Only vaccine, only immunoglobulin, wound care and vaccine plus immunoglobulin. Okay, Manoj, it's fantastic. Vaccine plus immunoglobulin is the correct answer. Yes. Yes, vaccine plus immunoglobulin. Right. Okay. So let us discuss and learn few points about vaccination in pregnancy. Okay. Vaccination in pregnancy. Okay. So let me tell you what all vaccines can be given during pregnancy and what all vaccines are contraindicated during pregnancy. Now listen, we have certain live attenuated vaccines. I have certain live attenuated vaccines on the screen, and most common among them are measles, mumps and rubella, the MMR vaccine. Then polio, yellow fever, varicella and smallpox vaccine. Okay. Now, tell me all of you, can we use these vaccines during pregnancy? Yes, live attenuated vaccines. Can live attenuated vaccines be used during pregnancy? What do you say? Yes? I think most of you all know this answer. Live attenuated vaccines are contraindicated during pregnancy. Okay? All these vaccines should be avoided during pregnancy. Live attenuated vaccines are contraindicated during pregnancy. Okay? So, MMR vaccine, polio, yellow fever, varicella and smallpox vaccines are contraindicated during pregnancy. And I have one question to you all here. Okay? Question is this. Okay, in fact, we had this question in one of the NEET exams, question in FMGE as well. In case a lady receives any live attenuated vaccine like say rubella vaccine, okay, how long should she wait after the vaccine to plan for pregnancy? Okay, so how many months should the lady wait before she conceives after taking a live attenuated vaccine? Yes? Yes? How many months should the lady wait? Supposing a lady has taken rubella vaccine, okay, suppose she has taken rubella vaccine, okay, in the pre-pregnant state. My question is, how many months should the lady wait before she conceives after taking the vaccine? Okay. Should the lady use contraceptive after taking the vaccine? Yes? Yes, very good, right answer. Yes, Nityanand, voice is lagging. I'm sorry, I think other people are able to hear. Ideal is 3 months, gamma knife, it's okay, but yes, the minimum period should be 4 weeks. 4 weeks is the correct answer. 4 weeks is the correct answer, okay. But then remember, at least 4 weeks, okay. The minimum should be 4 weeks and the ideal would be 3 months. 3 months, okay. Fine. Now, next question to you. In case the woman takes the vaccine during pregnancy, inadvertent exposure to the vaccine during pregnancy, is it an indication for termination of pregnancy? Okay. So, my question is, inadvertent exposure to this vaccine during pregnancy, inadvertent exposure to this vaccine during pregnancy, is it an indication for termination? Is it an indication for termination? Yes or no? Yes? This is not an indication for termination of pregnancy. Okay? This is not an indication for termination of pregnancy. Okay? Very good, Prashant. Okay? So, inadvertent exposure to these vaccines during pregnancy, live attenuated vaccine is not an indication for termination of pregnancy. Very important MCQ point. Okay? Okay, because all the risks that have been connected to these live attenuated vaccines are only theoretical. Okay, so we have not documented even one case of anomaly due to vaccination, okay, due to vaccination during pregnancy, okay. So the only live attenuated vaccine that can be given during pregnancy is yellow fever, okay. Vaccine against yellow fever, yes, can be given during pregnancy, and this is the only live attenuated vaccine that can be given during pregnancy, okay. Very important MCQ point. Okay, fine. Now coming to immunoglobulins, okay. Coming to other vaccines and immunoglobulins, okay. Fine. Now coming to influenza vaccine, okay. One of you tell me, can we give influenza vaccine during pregnancy? Yes, can we give during pregnancy influenza vaccine? Yes. Is it safe during pregnancy? Restart. Okay. Can you hear me? Okay. Guys, is there a problem now? Okay. Please wait. Okay, let me restart it. Please wait. Yes. Just wait. Okay. Okay, now I have tried to fix things up. So just let me try talking now. Okay, so we were talking about influenza vaccine, right? Okay, so can we give influenza vaccine during pregnancy? Yes, the answer is yes, influenza vaccine can be given to all pregnant women regardless of the trimester, okay, during flu season, okay. It can be given to all pregnant women regardless of the trimester during flu season because it is not a live virus vaccine, okay. Very important MCQ, it is not a live virus vaccine, okay. Now coming to the question that we had first, we had a question on rabies vaccine, right? So okay, fine. So rabies vaccine, yes, can be given, okay. Rabies vaccine, again it can be given because it is not a live vaccine, it is a killed virus vaccine, okay. Rabies vaccine is a killed virus vaccine and it can be given, okay. Now what is your opinion on hepatitis B and A? What is your opinion on hepatitis B and A, guys? Can we use this vaccine during pregnancy? Can we use this vaccine during pregnancy? Yes or no? Yes? Yes, Jyotsna, right. Your answer is right. Hepatitis B and A can be given whenever required. Exposure and post of infection. Yes, hepatitis B and A vaccines can be given during pregnancy because they do not contain the live viruses. Okay. So, on a nutshell, I would recommend few viral vaccines that can be administered during pregnancy. So, those viral vaccines that can be administered during pregnancy are, yes, flu vaccine, rabies vaccine, hepatitis A, hepatitis B. Okay. All these vaccines can be given during pregnancy. All these vaccines can be given during pregnancy whenever required. Okay. Fine. So, there is one viral vaccine which is not a live viral vaccine but still should not be used during pregnancy, and that is HPV vaccine, okay, human papilloma virus. So, is it a live virus vaccine? No, it is not a live virus vaccine, okay. It is a subunit vaccine, but then HPV vaccine should not be given during pregnancy, okay. HPV vaccine should not be given during pregnancy. Okay. Okay. Okay guys, let me stop this for a while. Guys, can you hear me now? Shall we start the session now? Guys? Okay. Sorry guys, let us continue. We were talking about vaccines, right? Okay. So, I told you there are few viral vaccines which can be given during pregnancy, okay, and they are influenza vaccine, rabies vaccine, hepatitis A and hepatitis B. Okay, so I told you there's one viral vaccine, despite being a subunit vaccine, okay, should not be given during pregnancy. Okay, it is not a live virus vaccine, but then it shouldn't be given during pregnancy. So what is that? Which vaccine is that? Yes, I told you about one viral vaccine which is not a live vaccine but still should not be used during pregnancy. Which vaccine is that? Yes, Manoj, Jayashree, Vicky, Avinash. Yes, HPV vaccine. Okay, HPV is not a live virus vaccine. Yes, very good. Okay, very good. HPV is not a live virus vaccine, but still HPV should not be given during pregnancy because the safety of HPV vaccine during pregnancy has not been documented yet. Okay, so it should not be given during pregnancy. All other non-viral vaccines can be given. Okay, now coming to bacterial vaccines. Okay, so we have certain inactivated bacterial vaccines. Okay, most important of them are pneumococcus, meningococcus and typhoid vaccine. So what's your opinion, guys? Can we give these bacterial vaccines during pregnancy? Pneumococcus, meningococcus and typhoid vaccines. Yes or no? Yes or no? Yes, they are not live vaccines. Again, yes, these vaccines can be given during pregnancy. Okay, these vaccines can be given during pregnancy. Okay, pneumococcus, meningococcus if required. Okay, on an SOS basis. Okay, so if required, these vaccines can be given during pregnancy. You all understand? Yes? Okay. Now coming to immunoglobulins. Okay. So toxoids and immunoglobulins. What all immunoglobulins can be given during pregnancy? Almost all immunoglobulins can be given during pregnancy, especially immunoglobulins. Yes, rabies, tetanus, varicella and hepatitis A. Okay, almost all immunoglobulins can be given during pregnancy. Okay, so immunoglobulins against hepatitis B, A, rabies, tetanus and varicella can be given during prophylaxis with immunoglobulin can be given during pregnancy. Okay, can be given during pregnancy. Okay, so we've discussed chickenpox in pregnancy many times because chickenpox is a teratogenic virus, right? Chickenpox and rabies, chickenpox and rubella are all teratogenic viruses, right? Okay. Immunoglobulins can be given during pregnancy, but within how many days? Okay, or what is the cutoff period before which you can give this immunoglobulin, varicella zoster immunoglobulin, beyond which that immunoglobulin is of no use? Yes, so before the appearance of rash or after the appearance of rash, when should you ideally give this varicella zoster immunoglobulin during pregnancy? Yes, varicella should be given before the appearance of rash. Okay. Varicella zoster immunoglobulin should be given before rash appears. Okay. So these immunoglobulins are absolutely safe during pregnancy and they can be given during pregnancy whenever required, especially after exposure. Okay, after exposure. Okay, so yeah, very good, Barney, very good. Okay, so the use of vaccines and immunoglobulins during pregnancy. So now tell me in a nutshell, what all vaccines are supposed to be given during pregnancy? Vaccines that are vaccines or toxoids, I would say, vaccines that are supposed to be given during pregnancy. Yes, what are all the vaccines that are supposed to be given during pregnancy? Yes, number one is tetanus toxoid. Okay, now we're giving what? Yes, diphtheria. Now we're not giving only tetanus, we're giving diphtheria, tetanus, pertussis combo. Okay, we're giving Tdap. Okay, we're giving Tdap. We're giving diphtheria, tetanus, pertussis combo. Okay. Sir, this tell me, what is the ideal gestational age to administer this vaccine during pregnancy? What is the ideal gestational age? Come on, tell me, when should we ideally administer this vaccine, this toxoid during pregnancy? Yes, between 26 and 37 weeks, okay, in the second trimester, okay, or in the third trimester, okay. Between 26 and 37 weeks should we administer 1 dose of toxoid, okay. The second important vaccine that we usually give during pregnancy, is influenza vaccine, okay, influenza vaccine, okay, during pregnancy. Yes, gamma knife, you're correct. 26 weeks is the perfect answer, okay, influenza vaccine. Okay, the next important vaccine and the most happening one, now the vaccine that can be given during pregnancy is corona vaccine, okay, COVID vaccine, okay. Tell me, can COVID vaccine be given during pregnancy? What does the government of India recommend? Yes, what does the government of India recommend? Tell me. Gamma knife, Jyotsna. What gamma knife? Why in USA only? Because it is not available in our government institutions, it doesn't mean we should not give, okay. If it is a flu season and if the woman is affordable, yes, we can give flu vaccine. Here, yes, we can give flu vaccine, okay. So, corona vaccine, can it be given? Yes, it can be given, right, okay. So, all of you all correct, okay. So, these vaccines are vaccines that we currently use during pregnancy, okay. These vaccines are vaccines that we currently use during pregnancy for all antenatal women, okay. Apart from these vaccines, there are specific vaccines which are used on an SOS basis whenever required, and those are rabies vaccine, hepatitis vaccines and so on, okay. Fine. So, this is about vaccine in pregnancy. So, you all understand. The additional calorie requirement during pregnancy. What is the additional calorie requirement during pregnancy? Additional calorie requirement during pregnancy. This is an old NEET PG question, okay. So, here is in the first trimester, the additional calorie requirement is 85 kilocalories per day, 85 kilocalories per day, and this is in addition to, her daily requirement, okay. This is in addition to her daily requirement, okay. Supposing a lady requires 1900 kilocalories, someone who is very sedentary, if she requires 1900 plus 85 will be her requirement in the first trimester, okay. If she requires say 2200, 2300 in the non-pregnant state, she would require another 85 along with a routine requirement during pregnancy in the first trimester, okay. So, 85 kilocalories per day in the first trimester, 285 kilocalories per day in the second trimester, and 475 kilocalories per day in the third trimester, okay. 350 and on an average is okay. It is okay. Gamma knife 475 according to Indian guidelines in all trimester. No, Kanna, no, in all trimester. No, okay. In the first trimester, we require very little additional calories. In fact, in one place, Williams mentions this as 0. Okay. In one place, Williams textbook of obstetrics, it mentions this value as 0. Okay. And in fact, we had this question in NEET PG exam. This is a NEET PG question. We had this question 2 years back in NEET PG exam, and there is no surprise, you can get this in FMGE too. Okay. So, 0 or 85 both are correct, but if in case you have this answer 85, then that would be the best answer. Anything between 0 and 85 you can actually choose, okay, out of which the best answer will be 85, okay. The second trimester it is 285 and in the third trimester it is 475. You need not expect the examiner to give the exact value whatever is given in Williams, okay. Now, I have written whatever is given in Williams here, but yes, you can choose the closest answer, okay, according to the options you can choose, okay, you can choose the closest answer. Oh yes, DPT single dose only, okay. So, this is about the additional calorie requirement during pregnancy, 85, 285 and 475, okay. So, we have a variant, that is the recommended daily dietary allowance during pregnancy, recommended daily dietary allowance during pregnancy. Okay. Now, we had one question in the last INI CET as well as 2 years back we had one question in FMGE also. Okay. Now I'll tell you, Jyotsna, 350 is kind of the close, I mean, an average for the second and the third trimester, Kana. It should be an average value, okay. So just don't go with this value 350. Remember only this, okay, 85, 285 and 475. 350 should be the average for the second and the third trimester. Okay. So now I'll tell you this question, dietary allowance. Now we're talking about dietary allowance, okay. So the question was like this in the last INI-CET exam, okay. Which of the following vitamin, okay, is the dietary allowance of which of the following, or the RDA of which of the following vitamin is high during lactation? That was the question, okay. And the options were vitamin A, D, E and K, okay. Come on, give your answers. Yes, Akash, Manoj, Jyotsna, Yashwant. Why all of you are giving 350? I think you learned 350 somewhere. That's okay. Okay, 350 should be the average of 285 and 475. Okay, so it's a rough value. Okay. Okay. Come on, now answer this question. Okay, the question is, which of the following vitamins, okay, take the help of the screen, which of the following vitamins RDA is more during lactation when compared to pregnancy? Yes? Yes, Barney, you're correct. Yes, which of the following vitamins RDA is more during lactation than pregnancy? Yes? Okay, vitamin A is the correct answer. Vitamin A is the correct answer. As you can see on the screen, vitamin A, the daily requirement of vitamin A, during pregnancy is 770 microgram. During pregnancy is 770 microgram, and during lactation it is 1300 microgram. Okay, during lactation it is 1300 microgram. So Arvind, vitamin E, of course there is a difference between the daily requirement during pregnancy and lactation for vitamin E too, but the difference is not as much as you see with vitamin A. You'll understand. The difference with vitamin E is not as much as you see with vitamin A. With vitamin A, the difference is almost gross. The RDA of vitamin A is almost double the RDA of vitamin A during pregnancy. I mean, during lactation, it's almost double of that you require during pregnancy. Okay. So, yes, calorie requirement is also high during lactation when compared to pregnancy. Yes, okay. So this is a very important MCQ, and this was the MCQ we had in INI-CET 1 year back. Okay. Now, water soluble vitamins have not been asked. If you can remember, because we do not know when the examiner will ask what. Okay. So, but when compared to other values, these are not very important. Now, there is one other very important catchy MCQ here. What is the calcium requirement during pregnancy? What is the calcium requirement during lactation? Okay, calcium requirement during pregnancy is 1000. Okay, calcium requirement during pregnancy is 1000. Calcium requirement during lactation is again what? 1000 milligram. Okay, again pregnancy, lactation, 1000 milligrams. See, very important catchy numbers, and I have picked this table. So, Williams Obstetrics 25th edition and 26th edition have very important data on the daily requirement of certain important vitamins and minerals. Okay, out of which please remember the calcium requirement during pregnancy and lactation are almost the same. Okay, 1000 milligram per day. Okay, fine, Akash. So maybe your PSM book says 1200. Williams says 1000. Okay, anyway, they're not much different from each other. Okay, one important is the iodine requirement during pregnancy and lactation. Very important MCQ. Iodine requirement during pregnancy and lactation. Okay, so what is the iodine requirement during pregnancy? The iodine requirement during pregnancy is 220 microgram per day, 220 microgram per day. And the iodine requirement during lactation, the iodine requirement during lactation is 290 microgram per day. The iodine requirement during lactation is 290 microgram per day. Okay, so 250 is almost correct. HN, you're very close to the answer, but please remember this question, I'm stressing on this one because this was asked in FMGE. Okay, this was asked in FMGE 3 years back, and this is a repeat question. We also had this question in NEET PG exam in 2018. Okay, what is the iodine requirement during pregnancy and lactation? Very, very important MCQ points, and these points are picked line by line from obstetrics textbook of Williams. Okay, so 220 microgram and 290 microgram are the most appropriate answers. Okay, iodine requirement during pregnancy and lactation. Okay, is it okay? Yes. Okay, are you able to follow me? Aditya, Manoj, thumbs up here. If you people are able to follow me, give me a thumbs up here. Yes? Give me a thumbs up. If you can follow me. Yes? Okay, okay, fine. So we had one question in the last INI CET exam, which again is a very straightforward question which can be expected in FMGE 2, and the question goes like this. Which of the following investigation is not mandatory during pregnancy? Which of the following investigation is not mandatory during pregnancy? Okay, is not mandatory during pregnancy, and the options were HIV, VDRL, echo, HIV, VDRL, echo, and blood sugar. Okay, what is your answer? Yashwant, Spandana, Taslima, Kanika, what is your answer for this question? Which of the following investigation is not mandatory during pregnancy? Not a baseline investigation, not mandatory, or in other words, I would put not a baseline investigation. Yes? What is the answer? Yes, very good, very good. Echo is the correct answer. Echo is the correct answer. Echo is not a baseline investigation, Kana. Okay, Rogan, HIV and VDRL are must during pregnancy. Okay, HIV and VDRL are must during pregnancy. For those who think it is VDRL, please do not skip VDRL during pregnancy. It is a must. Echo is the investigation that is optional during pregnancy. So, these are during pregnancy. Okay, and they are hemoglobin and hematocrit, blood grouping and RH typing. Okay, blood grouping and RH typing, blood glucose, VDRL. So this blood glucose estimation can either be with OGCT or OGTT, does not matter, but blood sugar estimation is very important during pregnancy. Yes, VDRL is important during pregnancy, HIV is important, HPSAG is important during pregnancy, urine microscopy and urine culture. Okay, so urine culture is also important. Now if I include urine culture, if I remove VDRL and if I put urine culture, then you people would pick urine culture, right? Because you all think urine culture is not a mandatory investigation during pregnancy. Urine culture is important during pregnancy. We do it, I mean, we do not routinely do it, but still the guideline recommends doing urine culture. Why? Because we have a condition called asymptomatic bacteriuria. I don't know how many of you are aware of it. Asymptomatic bacteriuria. Okay, asymptomatic bacteriuria, and this asymptomatic bacteriuria needs to be treated during pregnancy. Otherwise, this asymptomatic bacteriuria can lead to preterm labor, it can lead to It can lead to pyelonephritis. Okay. So this has to be treated during pregnancy, for which you require urine culture as well. Okay. Now hemoglobin, hematocrit, blood grouping, blood glucose, VDRL, HIV, HBsAg, urine microscopy and urine culture. Okay. So these are the antenatal investigations that are mandatory during pregnancy. Okay. Now there are certain investigations that are optional but are usually done. Okay. What is your opinion about, yes, they are all mandatory. Okay. What is your opinion about serum TSH? Serum TSH, Akshay, Sonali, Spandana, Rogin, tell me, serum TSH, is it a mandatory investigation? Serum TSH, Aditya, serum TSH, is it a mandatory investigation? Tell me. Yes? Okay, let me tell you, serum TSH is optional. Okay, you would be surprised to know this point, but yes, it is true. Serum TSH is not a mandatory, it is not a baseline investigation, and in fact, the ACOG guideline recommends serum TSH only in those women who are suspected to have hypothyroidism or hyperthyroidism, like say the woman has had previous abortions, the woman has had a baby with delayed milestones. Okay, so only in those conditions, TSH, I mean the guideline recommends doing TSH, or else serum TSH is not a mandatory investigation. But I agree to the point that we are doing TSH to all pregnant women in our community. Okay, we are doing TSH to all pregnant women in our community, but the guideline says it can be omitted. It can be omitted if required. Okay, so serum TSH is not a mandatory investigation, they are optional. Okay, so these are optional investigations. Okay, so we had this question in the last very recent INI-CET exam, the INI-CET exam that we had few days back. Okay, so this again is a very important MCQ area. Okay, fine. So the last MCQ area under antenatal care is about ultrasound scan. Okay, ultrasound scan. Okay, fine. So question to you guys, when do we do the first ultrasound during pregnancy? When do we do the first ultrasound during pregnancy? If you have to pick one gestational age, tell me what gestational age will you pick for the first ultrasound? Yes, the first ultrasound should be done at 6 weeks of pregnancy. Okay, the first ultrasound should be done at 6 weeks of pregnancy. 6 weeks of pregnancy, because that is when cardiac activity can be picked with a transvaginal probe. Okay, so this confirms the cardiac activity. This tells you whether it is a viable pregnancy or a non-viable pregnancy. This also tells you whether it is a singleton or a twin pregnancy. Singleton or a twin pregnancy. It also tells you whether it is intrauterine or extrauterine. Okay, it also tells you whether it is intrauterine or extrauterine. Okay, and little bit about the gestational age also, though this is not the ideal time to confirm the gestational age. Okay, yes, you get little information on the gestational age also. Okay, so tell me, if at all you have to confirm the gestational age with ultrasound. Okay, what is the ideal time to do the scan to get the gestational age with ultrasound? Okay, tell me, when do you do the next scan? When do you do the next ultrasound? Yes, when do you do the next ultrasound? After 6 weeks, when do you do the next ultrasound? Tell me one particular week, all of you. Yes, one particular week. Manoj, Amirul, Ayushman, Kuldeep, Karima, come on. When do you do the next scan? Yes? Okay, let me tell you, the next scan is ideally done at 12 weeks. Okay, the next scan is ideally done at 12 weeks. 10 to 14 is okay. 10 to 14 is okay. Okay, 10 to 14, but 12 is the most appropriate answer. Now also tell me, what are we trying to measure in this scan? 11 to 14 is the ideal time. 12 is the single best answer. 11 to 14 is the range and 12 is the single best answer. So tell me, what are we trying to measure? What are we trying to measure in this? Yes, two important parameters we're measuring here, and what are they, Kana? Yes, Okay, let me tell you, we're going to measure a very, very important parameter that is nuchal translucency. Nuchal translucency. We're also going to measure the crown rump length. Crown rump length and the nuchal translucency, and these two can be measured at 12 weeks. Okay, these two can be measured at 12 crown rump length, okay, and nuchal translucency. So crown rump length is basically to date the pregnancy. Crown rump length is basically to date the pregnancy, to find out the gestational age. What is nuchal translucency for? Nuchal translucency is to screen for aneuploidies. I wouldn't say confirm aneuploidy, I would only say screen for aneuploidy. Yes, nuchal translucency is to screen for aneuploidy and also certain anomalies like cardiac anomalies. So nuchal translucency is not specific for aneuploidy. Nuchal translucency is also increased in certain anomalies like cardiac anomalies. Okay, so nuchal translucency is what we measure at 12 weeks. Okay, nuchal translucency is what we measure at 12 weeks. Is that okay? Okay, fine. So this is about antenatal care. Any questions here? Any questions here? Yes? Downs. Is it yes, aneuploidy means chromosomal abnormality. Yes. Aneuploidy means, yes, it's chromosomal abnormality. Okay. Fine. So this is about antenatal care. So we've studied about a little about the epithelium, different types of epithelium. We've also studied about the different WHO recommendation on the number of visits. We've also discussed about the prophylactic iron and folic acid. We've discussed about different vaccines that can be given during pregnancy. We've also discussed about the dietary allowances, okay, daily dietary allowances and the calorie requirement during pregnancy. And last but not the least, we've also discussed about the investigations, okay. So I think you now have an overall idea on the antenatal care, okay. Now let us discuss about antepartum fetal surveillance. And in antepartum fetal surveillance, now I'll tell you one question here, okay. Antepartum fetal surveillance, we will discuss about biophysical profile and modified biophysical profile, okay. So first question to you guys, what is biophysical profile otherwise called? Biophysical profile otherwise called as? This is the first question to you. I'll tell you the question. Now tell me, what is biophysical profile otherwise called as? Biophysical profile, what is it otherwise called as? Okay. Okay, this is otherwise called as Manning score. Okay, Manning score. Biophysical profile is otherwise called as, can you hear me now? Can you hear me now? Yes? Krishna Kumar, Manoj? No, Kanna, no. Kumar, biophysical profile is otherwise called as Manning score. Biophysical profile is otherwise called as Manning score. Okay. Now, how many components do we have in biophysical profile? We have 5 components in biophysical profile. Okay. We have 5 important parameters in biophysical profile. Okay. Yes, correct. Manning score. Jyotsna, it's right. It's Manning score. Okay. Now, what are the components in biophysical profile? They are number one is NST. NST. Number two is fetal tone. Number 3 is fetal breathing movement. Fetal breathing movement. Number 2 is fetal body movement. Number 4 is fetal body movement. Okay. And number 5 is amniotic fluid volume. amniotic fluid volume. Okay, so we have 5 important parameters under biophysical profile. Fetal tone, fetal breathing movement, fetal body movement, and amniotic fluid volume. Okay, so now tell me, what is the score given to each of these parameters? What is the maximum score given to each of these parameters? Anybody? What is the maximum score given to each of these parameters? Okay. Now the maximum score given to each of them. Yes, Garima is correct. Okay. Maximum score given to Garima, NST, fetal tone, fetal breathing movement and body movement are right, Kana, but AFI is wrong. Okay. AFI is wrong. See please, all of you all, doctors, all of you all, see here I have written only amniotic fluid volume. I haven't written amniotic fluid index because this is not amniotic fluid index. Okay. So if it is not amniotic fluid index, what is it then? I'll tell you. Okay. For now you listen. Okay. Now NST, there is something called reactive NST. There is something called reactive NST. Okay. What is reactive NST? What is reactive NST? Yes, if there are two accelerations, that means increase in heart rate. Acceleration means increase in heart rate. Okay. By how many beats? By 15 beats per minute. By 15 beats per minute. Persisting for how many seconds? Persisting for 15 seconds. Persisting for 15 seconds. Okay, so two accelerations, at least two accelerations, at least by 15 beats per minute, persisting for at least 15 seconds in a 20 to 40 minute NST. In a 20 to 40 minute NST. So the total recording time will be half an hour. The total recording time is 30 minutes. On an average, it is 30 minutes. Biophysical profile is recorded for 30 minutes. Okay. So this is called as reactive NST, and if this is there, I will give a score of 2. If this is there, I will give a score of 2. Okay. Right. Pooja is right. Okay. Next comes fetal tone. Fetal tone. Okay. So how do we assess the fetal tone here? Anybody with a correct answer? Anybody with a correct answer? Okay. Fetal tone is usually assessed by extension flexion movements. Okay. Extension flexion movements. So you all know the universal attitude is flexion attitude, right? If the baby is able to extend the arm and return to its flexion, at least once in this 30-minute observation period, then you give a score of 2. Okay. At least one extension with return to flexion, okay, in this 30-minute observation. If this is there, again you would give a score of 2. Okay. Next is fetal breathing movement. Okay. Mic wire. Okay. So fetal breathing movement. Okay. Now fetal breathing movement should at least be, there should at least be one episode. There should at least be one episode of fetal breathing. There should at least be one episode of fetal breathing lasting for how long? One episode lasting for 30 seconds. Okay, for 30 seconds. And if this is there, again you gave a score of 2. Okay. Fetal body movements. How many fetal body movements should be there? 3 fetal body movement. Okay, there should at least be 3 fetal body movement. 3 fetal body movement in this half an hour period. And if this is there, again a score of 2. Okay. Now finally coming to amniotic fluid volume. Okay, I am telling it is not amniotic fluid index. I am only telling you it's amniotic fluid volume. What does that mean? So if it is not amniotic fluid index, what else are we using here? Tell me guys. Yes? Garima, Taslima, Pooja, tell me what are we using here? We using another parameter called single deepest pocket, single deepest pocket, single deepest pocket. That means, like say, this is the pregnant lady's uterus. Okay, say this is the pregnant lady's uterus. Okay, now what we usually do is, you know, let's say this is the right side and this is the left side, and this is the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. We take vertical pockets, no? Yes, we take vertical pockets fluid like this, like this in all the 4 quadrants. Like say this is A, B, C and D. How do we calculate the amniotic fluid index? Amniotic fluid index is obtained by summing up all the 4. So A plus B plus C plus D will give you the amniotic fluid index. Okay. Now in case, so summing up all the 4 will give you the amniotic fluid index. Okay. Now, instead of summing up all the 4, if you measure all the 4 and pick only one which measures the largest, okay, that is single deepest pocket. Like say if this is 4 centimeter, this is 2, this is 3.5 and this is 2.5, you will measure all the 4, you will consider only this, okay. So that is single deepest pocket, okay. So what do we use here? We use single deepest pocket here, and if the single deepest pocket is more than 2 centimeter, if the single deepest pocket is more than 2 centimeter, again she gets a score of 2. Okay, the total score will be 10. The total score will be 10. Okay, now tell me, can the score be in odd numbers? Can the score be in odd numbers? The score can either be 2 or 0. Okay, the score can either be 2 or 0. So the minimum score will be 0 and the maximum score will be 10. Okay, the possible scores are 0, 2, 4, 6, 8, 10. The possible scores are 0, 2, 4, 6, 8 and 10. These are the possible scores. Okay, fine. So, how do we, you know, decide, how do we proceed further with these scores after doing a biophysical profile? Please remember, if the score is 10, if the score is 10, it's absolutely fine. Okay, so if the score is 10, it is absolutely fine. Okay, there is no need for urgent delivery. Okay, there is no need for urgent delivery. You can continue the pregnancy. You can continue the pregnancy. Okay, if the score is 8 again, it's fine. Okay, if the score is 8 again, it's fine. Continue the pregnancy provided Liker is normal. Okay, provided Liker is normal, provided Liker is normal. Okay, but if the score is 8 and the AFI is less or the Liker is less, okay, if the score is 8 and the Liker is less, you have to deliver. You have to deliver. Okay, if the score is 6, again, if the Liker is normal, you can repeat and repeat the biophysical profile, and if the biophysical profile increases when you repeat it, you can just continue the pregnancy. Again, if the score is 6 and the Liker is less, okay, you have to deliver, okay. Now anything below 6, 4, 2, 0 indicates severe hypoxia, and is a definite indication for delivery, okay, and is a definite indication for delivery. So hope you all understand this. Yes, okay. So guys, are you following me? Are you following me? Pooja, Taslima, Avinash? I'll tell you. Arvind, Jyotsna, okay. Scores, okay. 6 and below are bad scores. Even in 6, you can repeat and see. When, I mean, once you get a score of 6, you repeat biophysical profile. If it improves, it's fine. You can continue pregnancy. If it doesn't improve, or if the Liker is less, then you have to terminate, okay. But less than 6, anything less than 6, like 4, 2 and 0, it indicates severe hypoxia and you have to deliver immediately. Okay, so this is it. Now, there are some few minute important points which you need to know to, go to that extra edge and crack little more MCQs, which I will tell you now. Okay. Now, having understood this, the 5 important parameters, which is the first parameter to appear and which is the first parameter to disappear? That is the next important MCQ. Okay, that is the next important MCQ. Okay, the first parameter to appear is this: tone followed by movement, followed by breathing movement, followed by heart rate. Okay, just a minute. So fetal tone, fetal body movement, fetal body movement, fetal breathing movement, and finally reactivity of the heart rate. Okay, reactivity of heart rate. Okay, it appears in this order. Okay, this fetal tone appears by 7 to 8 weeks. Okay, the tone appears by 7 to 8 weeks, and 7 to 8 weeks. Body movement appears by 9 weeks. Breathing movement approximately by 20 weeks, whereas reactivity of the fetal heart. Reactivity of the fetal heart means what? Heart rate going up and down, okay. Before, this 26 weeks, so this usually appears by 26 to 28 weeks, okay. So before 26 to 28 weeks, let's say the 20th week or the 22nd week, the heart rate would be more on the stable side, okay. But it is only at 26 to 28 weeks the heart rate starts fluctuating nicely, going up and down, and that is when you get accelerations and decelerations and the variability and all. Okay, that is what we call as reactive NST, right? Okay, so this order, okay, it appears in this order. It appears in this order. Okay, now the next important question is, in what order does it disappear? In what order does it disappear? Okay, tell me. Dana, Manoj, Taslima. Yes, I will tell you. Manoj, Taslima, tell me, in what order does it disappear? Okay, that means whenever there is a hypoxia. Okay, the MCQ is like this. MCQ is like this. Which of the following is the first parameter to disappear? Which of the following is the first parameter to disappear? First one to disappear in case of hypoxia. What is your answer, Kana? First one to disappear in case of hypoxia. Okay, let's say this is option A, this is option B, this is C, and this is D. Okay, what is your answer here? What is your answer here? Okay, so Manoj says it disappears in the same order. Any difference of opinion? Avinash, Dana, Mukundan, we'll discuss liker, Kanna. Now answer my question. Now answer my question. Amniotic fluid. Okay. Oh, you're asking about the liker here. Okay, liker is the last one to, increase. No, liker, at 20 weeks is only around 300 to 400 ml, and then it increases, it reaches 1 liter by 36 weeks. Liker is the last one to appear. Now, competition goes between these 4. Forget liker. Competition goes between these 4. Now, I'm asking you, which of the following is the first one to disappear in hypoxia? BCDA is wrong. DCBA is correct. Okay, DCBA is correct. Okay, so please remember, it appears in this order and it disappears in this order. Okay, it disappears in this order. Okay, so which is the first one to disappear? Which is the first one to disappear in case of hypoxia? Now tell me, which is the first one to disappear in case of hypoxia? Yes, Taslima, Prashant, William, Barney. Come on, tell me, which is the first one to disappear in case of hypoxia? Yes? Yes, right, reverse order, D. Okay, reactivity of the fetal heart is the first one to disappear. Reactivity of the fetal heart rate is the first one to disappear in case of hypoxia. Okay, so last we have a very modified biophysical profile. Tell me, what is modified biophysical profile? Is NST plus AFI. Okay, modified biophysical profile has only two parameters and they are NST and AFI. Okay, modified biophysical profile has only two parameters and they are NST and AFI. Now, why do we use modified biophysical profile? Because biophysical profile includes tone, breathing, movement, body movement, and all these require ultrasound. Okay. You can't calculate a biophysical profile without the help of ultrasound. Rather, this modified biophysical profile has only NST and AFI, and that AFI can be measured instantly. Whereas to measure the fetal tone, breathing movement and body movements, you have to wait for 30 minutes. No. So that waiting period is not there when you skip those parameters and choose only NST and AFI. Okay. So now please understand the difference between biophysical profile and modified biophysical profile. Modified biophysical profile. In biophysical profile you have 5 parameters. In modified biophysical profile you have only 2. Not only this, in biophysical profile we measure the single deepest or the single vertical pocket to measure the Lie curve. Okay, to measure the Lie curve we use single deepest pocket, the single vertical pocket. Whereas in modified biophysical profile we don't use the single vertical pocket, rather we use what? Amniotic fluid index. Okay, we use amniotic fluid index. We do not use single vertical pocket here, rather we use what? Amniotic fluid index. Guys, are you all able to follow me? Can you all follow me? Yes? Give me a thumbs up now. Have you all understood what is biophysical profile and what is modified biophysical profile? What is the total score? What are the possible scores? And what all to do when the scores are like say 8, 10, 8, 6, 4 and below? Yes? Good, good. Okay. So this is about biophysical profile and modified biophysical profile. Okay. Now let's move on to the next topic. The next is about amniotic fluid. Amniotic fluid. Okay. Guys, this is your old FMGE question. Okay. This is the old. So we have almost discussed 3 to 4 important topics. Now we are entering into the 5th topic. Now tell me the answer for this question. Amniotic fluid index is highest during. What is your answer? We have 28, 32, 36 and 38 here. What is your answer, guys? 36. Jyotsna says 36. Yes, 36. Among the given options, 36 would be the correct answer. Among the given options, 36 would be the single best answer. But according to Williams, 34 is the single best answer. Okay. 34 weeks is the single best answer. Okay. But yes, among the given options, 36 would be the best answer. Okay. So quickly we will revise few more points on amniotic fluid. We will discuss about the source of amniotic fluid, the color of amniotic fluid, and the different colors, like the abnormal colors like green, yellow, brown and all that. Okay. We'll also discuss about the volume of amniotic fluid. Okay. Now coming to the source of amniotic fluid, all of you all tell me what is the source of amniotic fluid in the first trimester? Yes? In the first trimester, the source of amniotic fluid is maternal plasma. It is an ultrafiltrate of maternal plasma. It is an ultrafiltrate of maternal plasma. Okay. So, what is the source in the second trimester? Yes, who contributes in the second trimester? All of you all tell me. Second trimester. Yes. In the second trimester, it is fetal urine. In the second trimester as well as the third trimester, okay, from the second trimester onwards, it is fetal urine. Okay. So, apart from the maternal plasma and the fetal urine, there is okay, fetal skin. Okay. So, fetal skin, please remember, fetal skin keratinizes at 20 weeks and it stops contributing beyond 20 weeks. Okay. So, fetal skin contributes only up to 20 weeks only up to 20 weeks of pregnancy. Okay, so which is the overall most important source? Tell me, which is the overall most important source? Which is the overall most important? The overall most important source is fetal urine. Okay, the overall most important source is fetal urine. Okay, fine. So next, coming to the volume. Guys, tell me, what is the volume at 12 weeks of intrauterine life? What is the volume at 12 weeks of intrauterine life? It is very, very less. The volume at 12 weeks of intrauterine life is only 50 ml. Okay, it gradually increases. And reaches, all you have to remember is only, the maximum and at what gestational age. So at 34 weeks, it reaches 1000 ml. At 34 weeks, it reaches 1000 ml. Okay, 1 liter. Okay, and that is the maximum. Okay, this is the maximum, and from 36 onwards, so 34 to 36. 34 to 36 is when it maintains itself and it starts decreasing after 36. Okay, after 36 it starts decreasing. So what happens to term? Someone tell me what is the Leica level at term? What is the value at term? Anybody? Yes, Taslima, come on. Taslima, Robin, Dana. What is the volume of Leica at term? At term, it is only 800 ml. Okay, at term, it is only 600 to 800 ml, among which the single best answer will be 800 ml. Correct? Yes, 800 ml. Okay, so what happens in post-term pregnancy? What happens at post-term pregnancy? It rapidly decreases and comes to 200 ml at 43 weeks. Okay, 200 ml at 43 weeks. Very, very important point. Okay, it comes to 200 ml at 43 weeks. Okay, so this is about volume. If you remember this about volume, it's more than adequate. Okay, at 12 weeks it's 50 ml, 34 weeks 1000 ml, 36 weeks onwards starts decreasing. At term it's 800 and post term it's only 200. Okay, next is about the color of the Leica. Okay, so yeah, come on, tell me, what is the normal color? Normal color? Yes, Jyotsna, Vicky, Prashant, what is the normal color? It is straw colored. Okay, straw colored. Okay, pale yellow or colorless, maybe colorless also. Okay, or milky white. All of them are correct. All of these are correct. Okay, it can either be straw colored, or it can be colorless, or it can be milky white. All these are different variants of a normal Leica. You all understand? Okay, basically, a preterm Leica will usually be colorless. Okay, but a mature Leica, a term Leica is usually milky white or straw colored. Okay, term Leica is usually milky white or straw colored. Okay, preterm and term. This is a subtle difference. So both are correct. Okay, both are correct. Depends on the gestational age. Okay. Secondly, tell me, will it be clear or will it be turbid? Which is normal? Clear or turbid? Pooja, Lavanya, yes, you can. You can also watch ma. Okay. Lavanya, Pooja, Jyotsna, Barney, tell me whether it is clear or it is turbid. What is the nature of a normal Leica? I'm asking. Clear or turbid? Please remember, it is turbid. It is normally turbid. Okay, it is normally turbid. Because of what? Because of the presence of fetal hair. Okay, fetal hair. Okay, and the lanugo, the fetal hair or the lanugo and the vernix. Okay, fetal hair or the lanugo and the vernix. Okay, vernix is that white like material that covers the fetal skin. No? Okay, so because of these things, the liquor is turbid. Okay, normally it is turbid. Okay, very good, Kana, very good. It is turbid and it can be colorless or milky white. Okay, so about green, we have brown, we have red, we also have saffron, and we have golden yellow. Okay, now quickly tell me, where do you see green? Where do you see green? This is very common, no? Most of you all know, almost all of you all know. Okay, let me not waste time on this. Green is seen, okay, green is meconium stain liquor. Green is meconium stain liquor. Okay, so why is meconium is a sign of fetal distress? You all know that, right? Meconium is a sign of fetal distress. Okay, so why is there a passage of meconium when the baby is in distress? Yes, because when the baby is in distress, you know, all the sphincters relax. Okay, when there is hypoxia, all sphincters in the body relax, including the lower anal sphincter. So when the sphincter relaxes, the baby passes meconium, which mixes with the amniotic fluid. So it's a sign of hypoxia. Okay, next is brown. Where do we see brown colored liquor? We see brown colored liquor in intrauterine death. Okay, so since this is a rapid revision program, I'm going very fast. Okay, so let me not waste time on all these because it's all much known to you. Okay, brown colored liquor is otherwise called as tobacco juice liquor. Okay, what is it otherwise called as? It is otherwise called as tobacco juice liquor. Tobacco juice liquor. Okay, next is red colored liquor. Okay, red colored liquor is seen in abruptio placentum. Okay, red colored liquor is seen in abruptio placentum. Abruptio placentum. Okay, next is saffron. Saffron colored liquor. Where do you see saffron colored liquor? Yes, post-dated pregnancy. Saffron colored liquor is seen in post-dated pregnancy. Saffron color is otherwise greenish yellow. Saffron color is otherwise greenish yellow or orange, or greenish yellow is again kind of orange. Okay. Finally, golden yellow. Yes, golden yellow is seen in jaundice. Right, you're correct. Lavanya, Hechin. Yes, you're all correct. Finally, tell me, where do you see golden yellow? Golden yellow is seen in RH incompatibility. RH incompatibility. Okay, RH incompatibility. Okay, so green, brown, red, saffron and golden yellow. Okay, meconium stained, intrauterine death, abruptio placenta, post-dated pregnancy and RH incompatibility respectively. Okay, so these are the abnormal colors. Okay, so this is your last FMGE question, the very recent FMGE question. When is the LICA volume maximum? The LICA volume is maximum at 34 to 36 weeks. Okay, fine. So let's move on to the next topic. I think you had the causes for oligohydramnios and polyhydramnios, it's kind of a huge table, and so I'm just trying to skip that. But in case you want it, let me show that. Okay, so because this is going to be available in YouTube for some more days, you can just take a screenshot if you want. Okay, so from the YouTube you can just take a screenshot of this. So this is the list of conditions leading to polyhydramnios. Okay, condition leading to polyhydramnios. Okay, so what are those conditions which lead to polyhydramnios? Anencephaly, hydranencephaly, holoprosencephaly, cleft lip and cleft palate because the baby cannot swallow properly, micronathia, small mouth because the baby cannot swallow properly. Okay, mass, any mass that obstructs the esophagus and prevents the fetus from swallowing, like say neck venolymphatic abnormality and cavus, diaphragmatic hernia, cystic adenomatoid malfunction and pulmonary sequestration. These all are mediastinal obstructions which prevent the baby from swallowing properly. Okay, so these are high cardiac output states because there is high cardiac output, there is excess LICA, there is excess urine output, there is excess LICA. Okay, so cardiomyopathy and myocarditis. Next is arrhythmias like flutter fibrillation and supraventricular tachycardia. Okay, heart block, esophageal atresia, duodenal atresia, because the baby cannot swallow. Whenever the baby cannot swallow, basically liquor is replaced by swallowing, no? Yes, whenever the baby cannot swallow, all the liquor that has to be replaced by swallowing will retain in the amniotic compartment, and again it will lead to polyhydramnias. That's the idea behind it. Okay. So yes, uretropelvic junction obstruction, Bartter syndrome, arthrogryposis, and certain neoplasias like sacrococcygeal teratoma, nephroma, chorioangioma. All these are causes of polyhydramnias. Okay, causes of polyhydramnias. Now there are certain things which are not mentioned here, which are in fact the frequent causes of polyhydramnias. The overall most common cause of polyhydramnias, that is the MCQ. Most common cause of polyhydramnias. Yes, come on, give me the answer now. So I have told you a whole list of causes for polyhydramnias. No, forget all that. Now tell me, which is the most common cause for polyhydramnias? Tell me that. Yes, which is the most common cause for polyhydramnias? Pooja, it's there. It's going to be there in YouTube, Kana. So you can very well take screenshots or take notes. So the PDF this time we're not giving. Okay. So Lavanya, HN, come on guys, tell me, which is the most common cause for polyhydramnias? GI cause, no Kana, there are two causes which are not mentioned here. I mean, that is what I'm expecting from you. There are two causes which are not mentioned here. In fact, yes, correct Lavanya, yes, you're correct. Diabetes is the most common cause. Okay, diabetes is the most common cause for polyhydramnias. In fact, idiopathic is the most common cause for polyhydramnias. Okay, idiopathic polyhydramnias, but that will not be there in the option. Okay. So, if you ask me to be more precise, then I would say idiopathic polyhydramnias is the most common. Okay, idiopathic polyhydramnias is the most common. Then comes diabetes, and then comes multiple pregnancy. Okay, then comes multiple pregnancy. These are the commonest causes. Okay, these are the commonest causes. So, Jyotsna, Prashant and Dr. You people are very, very good. Dana, you're extremely good. Idiopathic, yes, is the most common cause, but idiopathic will not be given, Kana. Will not be given in the exam. Okay. So, in case you have idiopathic, let's say you have idiopathic, then you can go for idiopathic, or else diabetes would be the most appropriate answer. Okay. And then comes multiple pregnancy. Okay. Oligohydramnias. Causes of oligohydramnias. Okay. So, we have PROM, we have preeclampsia or vascular disease, we have uteroplacental insufficiency, we have postdated pregnancy, bilateral renal agenesis, autosomal recessive polycystic kidney disease. Please remember, any problem with urine output, any problem with the kidney will decrease the urine output and eventually lead to oligohydramnias. So, you know, polycystic kidney disease is one major kidney problem which can compromise renal function and ultimately lead to oligohydramnias. But then autosomal recessive versus autosomal dominant, which manifests in the fetal period. Autosomal dominant polycystic kidney disease manifests only in the adulthood. Right? So, ARPCKD, autosomal recessive polycystic kidney disease, is the one that leads to oligohydramnias and not ADPCKD. Okay. And similarly, remember, unilateral renal agenesis. Unilateral renal agenesis does not lead to oligohydramnias because one single kidney itself is adequate to produce enough urine. You guys got my point? One single kidney itself is adequate to produce enough urine, and that existing kidney hypertrophies and it compensates for the missing kidney. You understand, guys? Okay, so bilateral versus unilateral, which one leads to oligo? Bilateral or unilateral? Akash, your answer is correct, but tell me, renal agenesis, unilateral renal agenesis or bilateral renal agenesis? Which one actually leads to oligohydramnias? Tell me. Yes, only unilateral renal agenesis leads to oligohydramnias and not bilateral. Okay, I'm sorry, I'm making it ulta. Only bilateral renal agenesis leads to oligohydramnias and not unilateral. Okay, so PROM, preeclampsia, uteroplacental insufficiency, postdated pregnancy, bilateral renal agenesis, ARPCKD, multicystic dysplastic kidney, bladder outlet obstruction, megacystitis, microcolon, intestinal hyperperistalsis syndrome, persistent cloaca, I mean any problem with the urine output like say posterior urethral valve or urethral atresia, persistent cloaca, cyanomelia, and drugs like AC inhibitors, ARBs, and NSAIDs. Okay, so these are the causes for oligohydramnias. And again, here the question is, which is the most common cause for oligohydramnias? Now we discussed the most common cause for polyhydramnias, right? Come on guys, tell me the most common cause for oligohydramnias. Here don't tell me idiopathic because we have well-known causes, okay? Most of the time the cause is obvious, okay? So tell me among the known causes, you tell me which is the most common. Come on guys. Among the known causes, which is the most common cause of oligohydramnias? Come on guys. Jyotsna says renal agenesis, Krishna Kumar. Okay, let me tell you, Jyotsna and Krishna Kumar, renal agenesis is the cause for severe oligohydramnias or anhydramnias. Dana is perfectly right. Dana, you're perfectly correct. PRO okay, so Dana, you're perfectly correct. Okay, now in case PROM is not there, please go for postdatism. Okay, in case PROM is not there, go for postdatism, unless, I mean, as long as you don't see the word severe. Okay, now this is the PROM is the most common cause for oligohydramnias. In case the word severe is mentioned, then your answer will be renal agenesis. Okay, so what is the cause for severe, which is the most common cause of severe oligohydramnias or anhydramnias? What is the most common cause for severe oligohydramnias or anhydramnias? Yes, here your answer is bilateral renal agenesis. Bilateral renal agenesis. Hope I'm not confusing you people. It's very clear. It's very clear. If you don't see the word severe, if only you see the word most common cause of oligohydramnias, then your answer is PROM. If PROM is not there, then go for postdatism. Okay, PROM is the most common cause for oligohydramnias. What is the most common cause for severe oligohydramnias or anhydramnias? If you see the word severe, then your answer will be bilateral renal agenesis. Hope you all understand. If you've understood, give me a thumbs up here. Give me a thumbs up here. Yes? If you've understood, give me a thumbs up here. So this is about amniotic fluid. You can expect questions from amniotic fluid because amniotic fluid is one important topic from which you've been getting consistently, you've been getting questions since the last 3-4 years. Okay, fine, fine. Okay, so here we finished this topic. Next we'll move on to another from which we are expecting 1 or 2 MCQs, and that topic is molar pregnancy. Okay, that topic is molar pregnancy. So without wasting much time, let me tell you only important points here in molar pregnancy. Okay, so look at this MCQ, all of you. Look at this MCQ, all of you. Most common type of GTN is gestational trophoblastic neoplasia. GTN is gestational trophoblastic neoplasia. Okay, come on, give your answer. We have 4 options here: choriocarcinoma, invasive mole, placental site trophoblastic tumor, and epithelioid. Okay, thank you guys. Now come on, give your answer for this question. Yes, invasive mole, answer is correct. Vicky, Caffeine, HN, all of you all right. No, answer is not Yema. Choriocarcinoma is not the most common. Lavanya, invasive mole is the most common. Okay, now let's see the classification. Now, how do we classify gestational trophoblastic diseases? We classify gestational trophoblastic diseases into molar and non-molar. Okay, so under molar we have three varieties. Okay, so we classify gestational trophoblastic diseases into molar and non-molar. Molar and non-molar. Okay, so molar is where that villus pattern is present. Villi is present, so you call it molar. Okay, in case villi is absent, you call it non-molar. Okay, that finger-like projections in the placenta. If that is there, it's molar. If that is not there, it's non-molar. Okay, so under molar we have three varieties. Okay, they are complete mole, partial mole. The third is invasive mole. Okay, complete, partial and invasive mole. Under non-molar we have three varieties. One is choriocarcinoma, the second is placental tumor, and the third is epithelioid. Okay, the next is epithelioid. Okay, choriocarcinoma, placental site trophoblastic tumor and epithelioid. Okay, now we again divide this into benign and malignant varieties. Okay, benign and malignant varieties. Please remember these two are, the first two are benign varieties. Okay, complete and partial mole are benign varieties. These four, invasive mole, choriocarcinoma, PSTT and epithelioid, are malignant varieties. Malignant varieties. Okay, so here malignant variety only is called as gestational trophoblastic neoplasia. In common, they are all called gestational trophoblastic diseases. So if you see D here, gestational trophoblastic diseases, if you see D here, it includes both benign and malignant. Okay, but if you see N here, neoplasia, it includes only malignant varieties, and four are there: invasive mole, choriocarcinoma, PSTT and epithelioid. Okay, now among the benign variety, which is the most common? Among the benign variety, complete or partial, which is the most common, Kana? Among the benign variety, complete or partial, which is the most common? Okay, let me tell you, among the benign variety, complete is the most common. Okay, among the benign variety, complete is the most common. Okay, among the malignant varieties, invasive mole is the most common. Okay, among malignant varieties, invasive mole is the most common. Okay, so this is it. Okay, so yes, Jyotsna, that's right, complete. Okay, so this is something about the pathogenesis of complete and partial mole. Okay, pathogenesis of complete and partial mole. Okay, so complete mole versus partial mole. Complete mole is completely paternal. No, it is completely paternal. It is completely paternal. That means the ovum is empty. Empty ovum. Empty ovum. Okay. Now this empty ovum can either be fertilized by one sperm, or the empty ovum can be fertilized by two sperms. Or the empty ovum can be fertilized by two sperms. Okay. Two sperms. Okay. Now in case it is one sperm, the sperm that fertilizes the egg will duplicate. It will produce one more sperm, and those two sperms will now fuse and make the cell diploid. In case two sperms fertilize the egg, these two sperms which fertilize the egg will, fuse and make the cell diploid. Okay. So depending on whether one sperm, if it is, one sperm, we call it androgenesis. Okay, we call this process as androgenesis. Androgenesis, where in case only one sperm fertilizes the egg and that sperm duplicates and produce one other copy of its own and fertilization occurs among them, you call it androgenesis. Okay, now two different sperms fertilize the egg, you call that as diandry. Diandry. Okay, so what happens as a result? There are different combinations of these sperms. The sperms can be of the sperms can be of 23x, 23x, they can be of 23x, 23y, and they can be of 23y and 23y varieties. As a result, three different cells are formed. one can be 46XX, the other can be 46XY, and the third can be 46YY. But remember, this 46YY will not survive. They will not survive because for survival you need only at least one X chromosome, no? But these two can survive. XX and XY can survive. Okay. So now tell me, guys, tell me among the two which is more common in complete mole, 46XX or XY, which is more common in complete mole? Yes, very, very important MCQ, which is the most common karyotype of a complete mole? Come on, guys. Which is the most common karyotype in complete mole? Yes? Okay, let me tell you. 46XX is the most common karyotype in complete mole. Okay, 46XX is the most common karyotype in complete mole, and this is a very important MCQ point. Very important MCQ point. Okay, 46XX is the most common karyotype in complete mole. Okay, 90% of the complete moles are 46XX. 10% of them are 46XY. Okay, all the complete moles. Yes, right, Vicky. Because all the complete moles are diploid in nature, we call it diploid diameter. We call it diploid diameter. Okay? So, diploid diameter both contribute to complete mole. Androgenesis means one sperm, diploid diameter means two sperms. Okay, fine. So, in contrast to this, we have one more called partial mole. Okay, so what happens in partial mole? The ova is not empty. Partial mole, the ova is not empty. The ova has 23X chromosomes to which, you know, two sperms fuse. Okay, so here there is nothing called androgenesis. Here there is only diandry. Okay, two sperms. Okay, so here there is, in partial mole, there is no androgenesis. There is no androgenesis. Okay, androgenesis is not seen. What is seen is only diandry. What is seen is only diandry. Okay. Now here again there are different possible combinations like 23XX, 23XY and 23YY and all. But please understand the difference between complete and partial mole, that in partial mole we have one extra set of chromosome in the ova. Okay. So here three sets are there altogether. One from the egg, one from the first sperm and one from the second sperm. So altogether we have three sets of 23 here. Okay. So what are the different possible combinations here? From the egg, okay, and this is from the egg, and from the sperm we can either get 23XX or 23XY or 23YY. Okay, this is from sperm 1, say this is from sperm 2. Okay, these are the possible combinations. So ultimately it will be 69, no? 69XXX or 69XXY or 69XYY. All are possible. All these three are possible. Okay. Guys, now tell me, among the three, which is the most common karyotype in a partial mole? Which is the most common karyotype of a partial mole, guys? Tell me. Is it 69XXX or 69XXY or 69XYY? Which is the most common karyotype in partial mole? Yes? Come on, guys. Okay, okay. The most karyotype in partial mole is 69XXY. Okay, the most common karyotype in partial mole is, very good Jyotsna, very good. The most common karyotype in partial mole is 69XXY. Okay, so for a complete mole it is 46XX and for a partial mole it is 69XXY. Triploid, okay, but among the three triploids, which is the most common, whether it's triple X or XXY or XYY, that's the question. Okay, so XXY is the most common. Okay, so also tell me, guys, where do you see androgenesis? Guys, tell me, where do you see androgenesis, in complete or partial? Androgenesis is seen in, guys, androgenesis is a feature of complete or partial? Androgenesis is a feature of complete mole and not partial mole. Okay, androgenesis is a feature of complete mole and not partial mole. Okay, diandry is seen in both complete and partial mole. In complete mole it is diploid diandry, whereas in partial mole it is triploid diandry. Okay, in partial mole it is triploid diandry. Okay, so we'll see the list of complications. Going on to the next. 6 important H. Okay. The first H is for high HCG. High HCG. The second H is for hypertension because there is more chorionic villi, there is hypertension. The third H is for hyperemesis. The fourth H is for hyperthyroidism. Hyperthyroidism. The fifth H is for height of the uterus. Height of the uterus. Okay, before given gestation usually. And the last H is for hemorrhage. The last H is for hemorrhage. Okay. These are the 6 important H related to complications. High levels of HCG, hypertension, hyperemesis, hyperthyroidism, height of the uterus and hemorrhage. Okay. Apart from these, there can be, amenorrhea, okay, okay, followed by bleeding plus passage of grape-like vesicles. Passage of grape-like vesicles. Okay, amenorrhea plus followed by bleeding with passage of grape-like vesicles. And the woman can develop ARDS, the woman can develop perforation, the woman can develop sepsis, she can develop DIC, and last but not the least, she can also develop cyst in the ovaries because of excess HCG stimulating the ovary. And now tell me, what are those cysts called as? Vicky, Barney, Garima, Taslima, what do you call those cysts as? No, vesicular mass, cysts, what do you call these cysts as? Yes? Okay, these cysts are called as theca lutein cysts. Okay, very, very important MCQ point. These cysts are called as theca lutein cyst. Okay, theca lutein cyst. Okay, so these are the clinical features of clinical features and complications of molar pregnancy. Okay, hypertension, high HCG, hyperemesis, hyperthyroidism, hypertension and hemorrhage. Apart from this, we have amenorrhea followed by bleeding plus passage of grape-like vesicles, ARDS, perforation, sepsis, DIC, and theca lutein cyst. Okay, so theca lutein cyst bilateral. Okay, always bilateral, always bilateral. Can secrete androgen, can secrete androgen. Okay, and spontaneously resolve after treat the cyst separately. They spontaneously resolve after you treat the tumor. Okay, so these are the characters of theca lutein cyst, bilateral theca lutein cyst. Okay, okay. So what is the investigation of choice here? What is the investigation of choice? Guys, what is the investigation of choice here? Come on guys, what is the investigation of choice here? Yes? Okay, the investigation of choice is ultrasound. Investigation of choice is ultrasound. Okay, and the route of ultrasound, say transabdominal or transvaginal, will always depend on the size of the uterus. If the uterus is less than 12 week size, you go for transvaginal ultrasound. If the uterus is more than 12 week size, if the uterus is more than 12 weeks, then you go for transabdominal ultrasound. Okay, so if it's less than 12 weeks, it's transabdominal ultrasound. Ultrasound is the investigation of choice. Okay, so what do you see in ultrasound? Very good, Taslima. Very good. Snowstorm appearance. So what you can expect here is an image, guys. Okay, now look at this image. Basically there are vesicles inside. The vesicle has fluid in it. Okay, it has clear fluid in it. Okay, so what will fluid appear like in ultrasound? Like, will it be hyperechoic or anechoic or hypoechoic? How will it be? Yes, fluid usually appears black in ultrasound. Okay, fluid usually appears black in ultrasound. Okay. So here, because the vesicle has fluid inside it, the vesicle, is white and the fluid inside appears black, and the adjacent structures appear gray. Okay. So here there is a mixture of white, black and gray echogenicities. Okay. Anechoic, hyperechoic and hypoechoic mixed echogenic structure. Okay. So mixture of these colors, and this is what you call as snowstorm appearance. Okay. This is what is called as snowstorm appearance. Okay. Okay, this is what is called as snowstorm appearance. Okay, very, very important MCQ. Okay, this question is a very easy question. This question was there in the last FMGE exam again. 36-year-old comes with 10 weeks amenorrhea with severe persistent spotting PV. On examination, she is pale. The uterus is enlarged to 16 week size. So, what are the favorable points here? She is actually 10 weeks pregnant, but the uterus is 16 weeks. So, the uterus is big for the given gestation. No? Yes, the uterus is big for the given gestation. And also she has anemia. She has severe vomiting. I told you hyperemesis is one feature of molar pregnancy. Okay. And she is anemic. Okay. So, ultrasound shows snowstorm appearance. So, the diagnosis is hydatidiform mole. Okay. This is a very, come on, it's an easy question. It has become easy because of repeated discussion. It's a very favorite question for the examiners. Okay, especially for FMGE, it's a favorite question for the examiners. Okay, so tell me guys, how do you treat this condition? How do you treat this condition? What is the treatment of choice? Tell me guys, what is the treatment of choice? Yes? Suction evacuation is the treatment. Okay, suction evacuation is the treatment of choice. Okay, so the treatment is basically surgical. The treatment is basically surgical. Suction evacuation is the treatment of choice. Okay, hope you all can follow. Okay, so now listen. Three important MCQs are there after this. The first is what is post-molar evacuation. Guys, give me the answer for this question. What is the contraceptive of choice for post-molar evacuation? Combined pills, progesterone only pills, IUCD and barrier. Yes? Definitely, yes, correct. Akash, I don't know why you have deleted the message. You're absolutely correct. Combined oral contraceptive is the contraceptive of choice. Combined oral contraceptive is the contraceptive of choice. Correct. Mahesh is right. Okay. So, we don't use progesterone only pills and IUDs because progesterone only pills and IUDs can cause breakthrough bleeding, which we don't desire to have here, because this condition itself can lead to, excess bleeding. So, also we need to follow the patient, right? Okay. So, combined pill is the contraceptive of choice. We have another question here. Following molar evacuation, pregnancy should be avoided for. Guys, come on. This is another favorite question for the examiners, especially for FMGE. Guys, for how long should you avoid pregnancy? After evacuating a molar pregnancy? For how long should you avoid pregnancy after evacuating a molar pregnancy? Yes? The correct answer is? Here the most common wrong answer is 1 year. The correct answer is 6 months. Okay, the most common wrong answer is 1 year. The correct answer is 6 months. Okay, correct answer is 6 months. Okay. Yes, very good, very good. Okay, so last question from this topic, guys. Tell me, what is the incidence of malignancy with complete mole? What is the incidence of malignancy with complete mole? Akash, Taslima, Avinash, why are you guys telling 3 months? I don't know, does any textbook say 3 months? Previously it was 1 year and the guideline has changed to 6 months now. I'm wondering if I'm not aware of the recent one. Yes, it is 6 months. It is definitely 6 months. Guys, okay. So this is it. Finally, tell me, what is the incidence of malignancy? I'm just asking you this. The incidence of malignancy with complete mole. Where is the incidence of malignancy high? Where is the incidence of malignancy high? Yes, the complete mole, the incidence of malignancy is high. Excellent answer, Vicky and HN. Excellent answer. 15 to 20% is the correct answer. Okay. So, 15 to 20% is the incidence of malignancy with complete mole. With partial mole, it's very rare. With partial mole, malignancy is very rare. Malignancy is quite common with complete mole, and the incidence is around 15 to 20%. So, very good answer, Jyotsna, Vicky and HN. Okay. So, let us stop. Just hypertension, okay, hypertension in pregnancy. Okay, I have few important points to tell you here in hypertension complicating pregnancy. Just see this question here. All of you will see this question. Many conditions and factors are associated with increased risk of preeclampsia. So, we've moved to hypertension. Okay. Which of the following factor results in the greatest relative risk for a diagnosis of preeclampsia in the current pregnancy? Advanced maternal age, systemic lupus erythematosus, history of preeclampsia in a prior pregnancy. Guys, can you see the question here? Can you see the question here? Guys, tell me, which of the following risk factor, which of the following carries the greatest relative risk for the diagnosis of preeclampsia? Oh, excellent answer. Again and again, you people are impressing me. History of preeclampsia in a prior pregnancy, is the factor with greatest relative risk. Okay, so this is the factor with highest risk for development of preeclampsia in the current pregnancy. Very, very important MCQ. Very, very important MCQ. Okay, now I request you to learn this list. Okay, though the list looks bigger, I want you to remember this. Okay, because even in the recent INI-CET exam, we've had two questions from this topic, hypertension complicating pregnancy, and also this is a very, very important topic owing to the complications associated with it. Okay, so yeah, risk factors. Prior preeclampsia is the most important and the most common risk factor, most important. Okay, and chronic hypertension is the second most important. Age, extremes of age. Okay, who is at risk? Tell me, young woman or elderly woman? Who is at risk? Young woman or elderly woman? Who is at risk for preeclampsia? Yes, both very young as well as old. Young as well as old. Okay, extremes of age is at risk for preeclampsia. Nulliparity again is a risk factor for preeclampsia. Okay, so when I ask this question, most of the students would say multiparity is a risk factor, but no, nulliparity is the risk factor. Means any woman getting pregnant for the first time, then she is at risk for preeclampsia more than a woman who is pregnant for the second or the third time. Okay, so nulliparity is a risk factor. African American women are at risk for preeclampsia. Metabolic syndrome. So I hope you all know what is metabolic syndrome. Diabetes, hypertension, obesity and dyslipidemia. No, diabetes, hypertension, obesity and dyslipidemia. Okay, so metabolic syndrome is a risk factor, hyperhomocysteine is a risk factor, and surprisingly trisomy 13 is a risk factor. Yes, what is trisomy 13 otherwise called as? Trisomy 13 is Patau, right? Trisomy 13 is Patau. Okay, so multiple pregnancy is a risk factor, obesity, APLA, SLE. APLA and SLE, these are two autoimmune diseases which increase the risk for preeclampsia, abruption, IUGR, abortion, all these. Okay, so these are associated with many pregnancy complications. Okay, so multiple pregnancy, obesity, male fetus. Okay, I don't know how many of you are aware of this. Carrying a male fetus itself increases the risk of preeclampsia. Okay, so despite all these risks, our Indian women are very fond of carrying male fetuses, right? So carrying a male fetus itself is a risk factor for preeclampsia. HIV positivity, guys. HIV increases the risk of preeclampsia, okay. HIV increases the risk of preeclampsia, okay. Next is sleep disorder, sleep apnea, chronic kidney disease and ART. ART means IVF pregnancy. Okay. So, right, yes, Patau, okay. So, these are the risk factors for preeclampsia. Now, out of these risk factors, MCQ points, I would say the first and the most important risk factor is the most commonly asked question, and you all know prior preeclampsia is the most important risk factor, and not only for preeclampsia, for ectopic also. Past history of ectopic is the most important risk factor for ectopic pregnancy in the current conception. Okay, then comes chronic hypertension, then only comes diabetes and other factors. Okay, now there are certain factors which you can easily guess, like say the given question, whatever question I showed you now, even guys who do not know the, you do not have much knowledge on the risk factors can easily guess that the past history of preeclampsia is a risk factor. Okay, but there are certain things which you can't guess, like say Patau, okay, HIV, male fetus, okay, chronic kidney disease, ART and sleep disorders. These are things which you can't guess easily, okay, all these, so you should know. And guys, there are certain areas where usually students give the wrong answer or the opposite answer of what I expect, like say age and parity. When I ask for the age, students usually say old age is a risk factor, but please remember that both young and old are at risk. Okay, when I ask about the parity, students usually tell that multiparity is a risk factor, but please remember nulliparity is the risk. Okay, and there is one other point where students usually give me the wrong answer, and that is smoking. Smoking. Guys, tell me what is the effect of smoking on the risk of preeclampsia? Yes? What is the effect of smoking? Gum. Everything you can think of is a risk factor. Okay, fine, dear. Smoking, tell me dear, smoking. Come on. Let them not ask. Now tell me, smoking, they'll ask. Yes? Okay. Smoking decreases the risk of preeclampsia. Yes. Smoking decreases the risk of preeclampsia. Smoking is protective. Okay. No relation. No. Smoking is actually protective. Smoking is actually protective, Kana. Okay. It decreases the risk of preeclampsia. Okay. Okay. Important points here. The list looks really big and too much for an FMGE graduate, but yes, there are 4 to 5 markers which you need to know. In the last INI-CET exam, we had one question from markers in preeclampsia, but I'm not telling you to learn all that an INI-CET aspirant learns, but there are certain points which you have to learn as well. See here, markers, when it comes to markers, this marker, soluble FMS like tyrosine kinase, endothelin, soluble endoglin, okay, soluble endoglin, and I think this is it. Okay, these 3 markers you have to remember. Only 3. I'm asking you to remember only 3. Why I'm asking you to remember this? Because we have started using it in our clinical practice. That's why I'm asking you to remember these 3. Okay, soluble FMS like tyrosine kinase, endothelin and endoglin are factors which decrease angiogenesis. Okay, they are anti-angiogenic factors. They are anti-angiogenic factors. Okay. So, guys, I'm asking you to remember only 3. Soluble FMS like tyrosine kinase, endothelin and soluble endoglin. What happens to these parameters in women who are at risk for preeclampsia? In women who are at risk for preeclampsia, these parameters will increase. Okay. If these are high, then the risk is high. That's how it is. Okay. If these are high, the risk is high. Okay. Now, there are certain parameters which decrease when the woman is at risk for preeclampsia, and they are nitric oxide, PGI2, VEGF, and all growth factors basically. Okay. I want you to remember only 4. Vascular endothelial growth factor, placental growth factor, PLGF, that is PLGF, placental growth factor, prostaglandin I2 and nitric oxide. Prostaglandin I2 and nitric, all these are angiogenic factors. All these are angiogenic factors. Okay. So, these factors decrease, angiogenic factors, that means factors which help new vessel formation, decrease with increased risk of preeclampsia. On the opposite, factors that are anti-angiogenic. Okay, those that decrease new vessel formation increase with increasing risk of preeclampsia. I hope you all understand. Okay, because this question was there in the recent INI-CT exam. I'm just telling you the importance of this. Don't remember the entire list. 3 this side, 4 that side. Okay, lastly, remember one thing. PGI2 and thromboxane A2 ratio. This alone you remember. Okay, PGI2 thromboxane A2 ratio. Okay, this is angiogenic. This is angiogenic and this is anti-angiogenic. This is anti-angiogenic. Okay, so what will happen? This will increase, this will decrease for a woman at risk of preeclampsia. So overall, the ratio will decrease. Okay, because thromboxane A2 will increase, PGI2 will decrease, and the ratio will decrease. Okay, so this is it about preeclampsia. This chart. Okay, this chart. Okay, prevention, which is useful, which is not useful. Okay, so this again, this is one MCQ area which is, you know, from which questions have been repeatedly asked. So guys, please remember, smoking, regular exercise, bed rest, statins, metformin and aspirin, all these are useful in preventing preeclampsia. Okay, so you can ask all pregnant women to smoke. Regular exercise, smoking, bed rest, statins, metformin and aspirin, all these are useful. What are not useful? Low salt diet, calcium supplement, fish oil, diuretics, antihypertensives and antioxidants. Okay, so these are not useful. Okay, so left sided ones are useful and the right sided ones: low salt diet, calcium supplement, fish oil, diuretics, antihypertensives and diuretics and antihypertensives. Please remember, they are useful only after the woman has developed preeclampsia. Antihypertensives, giving antihypertensives, it makes sense only after the woman has developed preeclampsia. Okay, so we cannot use it for prophylactic purpose. Okay, so this is about preventing preeclampsia. Okay, now we have 2 questions here. Which of the following nutritional supplement has been shown to reduce the incidence of preeclampsia? Come on guys. Options are calcium, vitamin E and ascorbic acid. Don't think it's a, you know, it's a hi-fi question which is not for FMGE. It's a very simple question. It's a very, very simple question. Okay. Which of the following nutritional supplement has been shown to reduce the incidence of preeclampsia? Come on. Okay. Calcium, vitamin E, ascorbic acid, none of the above. What's your answer? Hchen and Vikas, after spending so much time on explaining what prevents, what is useful and what is not useful, if you give an answer like this, I'm so sorry guys. Just take the help of the previous slide I'm telling. Okay, just see the screen and then give the answer which is useful. Calcium, vitamin E and ascorbic acid. Vitamin E and ascorbic acid basically come under antioxidants. Kanna. Antioxidants. Vitamin E and vitamin C are antioxidants. Do they really help? Do they really help? Come on guys. No, they don't. Okay, they don't. It is just a simple FMG level question only. Okay, they don't help. Okay, none of these nutrients help. Okay. So you want what all cancer staging are important? Okay, cervix, endometrium, ovary. These are important. If time permits, you can read vulva or else you can omit important parts of the okay. So if you read the staging part, but before that, answer this question. Which of the following angiogenic factors are to proceed to develop preeclampsia? Which of the following angiogenic factors are elevated in women who proceed to develop preeclampsia? Yes? Yes, elevated. Soluble, FM is like tyrosine kinase. Okay. So this is an anti-angiogenic factor, as I already told you. So this is elevated in women who proceed to develop preeclampsia. Okay. So this is it about preeclampsia. Hypertension. Yes. Nifedipine, no, not nifedipine. Safest drug for hypertension in pregnancy. Why you people are telling nifedipine here? Yes. Methyl dopa, no, again. Safest drug for hypertension in pregnancy is labetalol. Okay, safest drug for hypertension in pregnancy is labetalol. Labetalol is the safest and the most recommended drug. No, not methyl dopa. The answer is labetalol. Definitely the answer is labetalol. Also tell me, what is the drug of choice? What is the drug of choice for seizures during pregnancy? Okay, or I would say eclampsia. I would not say seizures. Okay, what is the drug of choice for eclampsia? Yes? What is the drug of choice for eclampsia during pregnancy? Yes? Yes, the answer is magnesium sulfate. Okay. Okay. Anticonvulsant of choice. Anticonvulsant of choice to treat eclampsia is magnesium sulfate. Okay. Methyl dopa. No, no, Kana. No. Prashant. Dr. Prashant, labetalol is the safest drug. Labetalol is the safest drug. Okay. Fine. Why not methyl dopa? Tell me. Why not methyl dopa? Why not methyl dopa? Methyl dopa is not the drug of choice. It is neither the drug of choice nor the safest. Why? Because number one, methyl dopa leads to rebound hypertension. It is a centrally acting drug. Once you stop the drug, it will lead to rebound hypertension. Okay. Secondly, leads to postpartum depression. Okay, methyl dopa leads to postpartum depression. Yes, yes, correct. Okay, methyl dopa leads to rebound hypertension once you stop the drug. Methyl dopa leads to postpartum depression. Thirdly, methyl dopa is not as effective as labetalol. Labetalol is more effective than methyl dopa. Okay, not as effective as labetalol. But this is the third point. Most important points are two. One is rebound hypertension and the other one is postpartum hypertension. For these two reasons, methyl dopa is not the drug of choice anymore. Okay. So it has been updated long back. Labetalol is the safest and is the drug of choice to treat hypertension during pregnancy. Okay. Fine. So, straightforward points on magnesium sulfate. Straightforward points on magnesium sulfate. What are they? Point number one. Magnesium. The name of the regimen is Pritchard regimen. Okay, the name of the regimen is Pritchard regimen. Okay. We have loading dose and we have maintenance dose. And the loading dose is how do you give the loading dose? We give 14 gram in the loading dose. Okay, 10 gram diluted to 20% IV. 10 gram diluted to 20% IV infusion. IV infusion. Okay, and I'm sorry. 4 gram diluted to 20% IV infusion and 10 gram given as a 50% solution. 50% solution. 5 gram in each buttock, 5 gram in the right buttock and another 5 gram in the left buttock. Okay, 5 gram in the right buttock, another 5 gram in the left buttock. Okay. So, this is about the loading dose. Maintenance dose, we don't give IM anymore. Previously, we were giving it as IM, 5 gram IM every 4th hourly. Okay, but now the guideline recommends IV infusion only. Okay, 1 gram per hour infusion. Okay, we are not, the guideline is not recommending IM regimen for maintenance dose. The guideline is recommending continuous infusion, okay, for maintenance, and that will be 1 gram per hour, okay. So this is Pritchard regime. This is Pritchard regime, okay. Secondly, what is the mechanism of action here? What is the mechanism of action of magnesium sulfate? The mechanism of action of magnesium sulfate is, why would you give vitamin A in pregnancy? Come on, we don't give vitamin A. We are only discussing about the RDA. We are only discussing about the recommended dietary allowance. We're not giving, we're not discussing about any supplement. In fact, vitamin A is not supplementary. Action of magnesium sulfate is, number one, it blocks the calcium channels. Okay, it blocks calcium channels. Okay, it blocks. In fact, listen, whether you're a girl or a boy, listen. Magnesium, vitamin A is in fact teratogenic. Okay, you should not supplement pregnant women with vitamin A. High doses of vitamin A is teratogenic. Okay, so magnesium sulfate. Talking about magnesium sulfate, no, what is the mechanism of action of magnesium sulfate? It blocks calcium channels. Okay, it blocks calcium channels. That is the first mechanism of action. It also has NMDA blocking property. Okay, it also has NMDA blocking property. Okay, next is, yes, how do you monitor a woman with magnesium sulfate? Tell me, how do you monitor? Yes, how do you monitor? Yes, therapeutic index is very narrow. So even a marginal increase in the serum levels of magnesium would lead to toxicity. Okay. Deep tendon reflexes and respiratory rate. Okay, so respiratory rate should at least be 14 per minute. Respiratory rate should at least be 14 per minute, and urine output should at least be 30 ml per hour, and knee jerk should be present. Okay, knee jerk should be present. This is how we. Okay, so in case the lady develops toxicity, what is the usual therapeutic serum level? Okay, therapeutic serum level of magnesium, that is the next question. What is the toxic level? What is the sign of toxicity? What is the first sign of toxicity? Okay, and finally, when does respiratory depression occur? When does respiratory depression occur? 4 important MCQs. Come on, guys. Answer these 4 important MCQs here. What is the therapeutic level? Voice is breaking. Okay. So, what is the therapeutic level? Tell me, guys. What is the therapeutic? 4 to 7. Excellent answer. So, Prashant has given the best answer. 4 to 7 milliequivalents per liter. 4 to 7 milliequivalents per liter is the serum therapeutic level. Toxic level is 10 milliequivalents per liter. Toxic level is 10 milliequivalents per liter. And the first sign of toxicity, sign of toxicity is loss of knee jerk. The first sign of toxicity is loss of knee jerk. And when the respiratory depression loss of knee jerk is seen at 10 milliequivalents. 10 milliequivalents. Respiratory depression at 12 milliequivalents. Respiratory depression at 12 milliequivalents. These are important MCQ points that you have to remember. Each and every word that I have written here is an MCQ. Okay, what is Pritchard regime you have to know, what is the mechanism of action you have to know, how to monitor, what should be the minimum and what should be the minimum respiratory rate, and the serum therapeutic level, toxic level, and all these you have to know. Okay, what is the antidote? Finally tell me, guys, antidote, you tell me. What is the antidote? Okay, yes, respiratory depression, failure, and then arrest, anything beyond 12. Okay, antidote, guys, tell me what is the antidote? Very, very important MCQ. Calcium gluconate. Rule of 10. Rule of 10 means 10% calcium gluconate, 10 ml IV over 10 minutes. Okay, this is rule of 10. Rule of 10. Okay, 10 ml of calcium gluconate, 10% IV over 10 minutes, right? Okay, HN Prashant Avinash, you people are correct. 10 ml, 10% IV over 10 minutes, calcium gluconate. This is a rule of 10. Is it all fine to you? Okay. So, this is about antidote. What are the other properties of magnesium sulfate? Other properties of magnesium sulfate. Okay. Magnesium sulfate is a neuroprotective drug. Magnesium sulfate is a neuroprotective drug. Magnesium sulfate is a tocolytic drug. Magnesium sulfate is a tocolytic drug. Okay. So, tocolytic effect is seen only in high doses of magnesium sulfate, not in usual doses of magnesium sulfate, not in the dose that we give for anticonvulsant. Okay. It is neuroprotective and it is tocolytic. It is tocolytic. Is that fine? Okay. And finally, in case magnesium is excreted unchanged in urine, no. So, for this reason only we monitor the patient with urine output. Otherwise, magnesium does not harm the kidneys. Okay. It is the renal failure that leads to magnesium toxicity. Okay. And for this reason, we monitor the woman with urine output. Okay. So, in case there is renal failure, in case the kidney function is compromised, the creatinine levels are increased, what would you do? Will you avoid giving a magnesium sulfate for a woman who really needs it? What will you do? What will you do? Yes? Yes, Kanna. HN prevent cerebral palsy means? Yes, neuroprotective. Both are same. Okay. So, please from me, in case of renal failure, okay, in case of renal failure or in case of increased serum creatinine, okay, loading dose should not be changed. Loading dose should not be changed. Okay. So, I am just, okay, give plus dialysis. Okay. What I mean regarding the dose, I am asking you how much you will give. Okay. Loading dose should not be changed. Okay. Only the maintenance dose should be decreased. Okay. Only the maintenance dose should be decreased. Only the maintenance dose should be decreased here, not the loading dose. Is that okay? Yes. So, this is about magnesium sulfate. So, here we finish important points on hypertension complicating pregnancy. Okay. So, as you all requested, the last session of today's class, the last topic for today's class will be on staging. Okay. So, we will discuss only about the staging of cancer cervix and if time permits endometrium also. Okay. So, staging part. Okay. Staging of cancer cervix. Okay. So, quickly recall this. Staging of cancer cervix. Okay. This topic was not in the list that I prepared, but since you people are requesting, I am just including it now. Okay. So, we will discuss staging of cancer cervix now. Okay. Fine. And of course, this is important. So, let us not skip this. Okay. So, we have 4 stages here. What are they? Stage 1, 2, 3 and 4. Okay. What is stage 1? Stage 1 is a condition which is limited to the cervix, limited to the cervix only. Okay. Stage 2 is limited to the cervix. In turn, in stage 1 is limited to the cervix. In turn, in stage 1 we have 1A and 1B. Okay. What is 1A? What is 1B? 1A is a disease which is again divided into A1 and A2. Okay. 1A is a disease which is not visible to the naked eye. Okay. Not visible to the naked eye. That means it is microscopic. Okay. It is microscopic. Okay. 1B is macroscopic. Macroscopic means it is visible to the naked eye. Okay. We have 1A and 1B. 1A is not visible, 1B is visible. Okay. In turn, in 1A we have A1 and A2. Okay. In turn, in 1A we have A1 and A2. Okay. What is A1? less than 3 millimeter deep. If the lesion is less than 3 millimeter deep, you put it under A1, and anything which is 3 to 5 millimeter deep is A2. Okay, so depth. Previously we also included width. Okay, so it was like less than 7 mm will be A1 and more than 7 mm will be, you know, all these stuff were there, but now width is not there, only depth is there. Just remember less than 3 and 3 to 5. Okay, so A1 and A2, 3 is A1 and 3 to 5 is A2. This is 1A, and these are microscopic lesions. Okay, what is a B? B is macroscopic lesion, and in turn we have B1, B2 and B3. Okay, B1, B2, B3. Okay, what is B1? A lesion measuring less than 2 centimeter is B1. Lesion measuring 2 to 4 centimeter is B2. Lesion measuring more than 4 centimeter is B3. Okay, B1, B2 and B3. Less than 2 centimeter, 2 to 4 centimeter and more than 4 centimeter are B1, B2 and B3 respectively. This is about stage 1 of cancer cervix. Okay. Now again remember micro-invasive cancer. What is micro-invasive cancer? A1 is called as micro-invasive cancer. Okay, A1 is called as stage 1, A1 is called as micro-invasive cancer. Okay, this is about stage 1 of cancer cervix. Now coming to stage 2. Okay, now coming to stage 2 of cancer cervix. I want you to remember this diagram or the picture. Okay, now let's say this is the cervix. Now let's say this is the cervix, and let's say this is the uterus. Okay, now let's say this is the vagina. Okay, and say this is the lateral pelvic wall. Okay, lateral pelvic wall means the iliac bone. Okay, let's say this is the iliac bone. Okay, fine. Now I want you to draw 2 circles here. Okay, one circle will include, like you all know, there are ligaments connecting the uterus and the cervix to the lateral pelvic wall, right? So those that ligament which extends from the cervix to the lateral pelvic wall horizontally is the McEnroth's ligament or the transverse cervical ligament, and that ligament which extends from the posterior part of the cervix to the sacrum is the uterosacral ligament, right? So let me draw the McEnroth's ligament here. Okay, say McEnroth's ligament is that ligament which connects the cervix and the upper vagina to the lateral pelvic wall, which will be something like this. Okay, now I want you to draw 2 circles. The first circle will be the inner circle, and this circle will include the upper vagina and the medial half of the McEnroth's ligament. Okay, so this circle will be like this. Okay, and I want you to draw one other circle, the second circle, and that circle will include the lower vagina. It will also touch the lateral pelvic wall. It will touch the lateral pelvic wall. Okay, so now what does the inner circle represent? The inner circle is stage 2 and the outer circle is stage 3. Okay, so what all are there in the inner circle? In the inner circle we have the upper vagina, we have the medial parametrium. What does medial parametrium mean? What does parametrium means? See, this is the coronal section of the pelvis. Okay, the coronal section of the uterus. Now in case I make an axial section of the pelvis, okay, like say if this is the cervix, I cut it like this. Okay, like say this is the cervix, okay, and this is the pelvic bone, okay, and this is the pubic bone, and this is the sacrum. Okay, so this is pubis, this is sacrum, this is the iliac bone. Okay, now you have ligaments connecting the cervix to all the bony parts around the cervix, right? Okay, so let's say this is the transverse cervical ligament. Okay, let's say this is the ligament which connects the cervix to the pubis, that is pubocervical ligament. Okay, so this is transverse cervical, this is pubocervical, and let's say this is the uterosacral ligament, the ligament that connects the cervix to the sacrum. Okay, uterosacral ligament. So the cervix is anchored to bony structures all around, okay, by means of 4 ligaments. 2 transverse cervical, 1 uterosacral and 1 pubocervical. Okay, so it's just like anchoring the cervix to the bony structures all around. So in between these you have the connective tissue. Okay, so here you have the connective tissue. And what does this connective tissue have? This connective tissue has the lymphatics. Okay, this connective tissue has the lymphatics and the blood vessels. It has the lymphatics, it has the blood vessels, it has nodes. Okay, it has what? It has nodes. Okay, together I call this as parametrium. So what do I call as parametrium? The tissue that surrounds the cervix. Okay, the tissue that surrounds the cervix, which includes the ligaments, the various ligaments, the connective tissue, which again includes the blood vessels, the lymphatics, the nodes. All these together make what? Parametrium. It makes parametrium. Okay, so this parametrium can be divided into medial half and lateral half, right? Okay, so let's say this is the medial half of the parametrium. If this portion is involved, I will call it stage 2. Okay, and if outside is involved, outside means the lateral parametrium is involved, and if especially if it touches the lateral pelvic wall, like say the iliac bone or the pubic bone or the sacral bone, I'll call it stage 3. That's it. Okay, so hope you all following me. So this is stage 2. The inner circle will be stage 2, and in turn in the stage 2 I have 2A and 2B. Okay, in stage 2 I have what? I have upper vagina is 2A. Involvement of upper vagina is 2A. Involvement of the medial parametrium. Medial parametrium means not touching the pelvic wall. If it touches the pelvic wall, it becomes lateral parametrium. So it's stage 3. Okay, so involvement of medial parametrium is 2B. Involvement of upper vagina is 2A and medial parametrium is 2B. In turn, in 2A, we have 2A1 and 2A2. A lesion less than 4 centimeter. A2 is a lesion measuring more than 4 centimeter. That's so simple. Okay, so this is stage 1 and stage 2. Okay, so in case you've understood 2A and 3A and 3B, so if you have understood what is 2A and 2B, and if you have understood the two circles, it is very easy to guess what is 3A and 3B. Guys, tell me what is 3A and 3B. Are you people following me? Are you people following me? Yes? Guys, tell me what is 3A, 3B? Yes? Okay. 3A is involvement of lower vagina. 3A is involvement of lower vagina, and 3B is involvement of lateral parametrium. Okay. So 3A is involvement of lower vagina, and 3B is involvement of lateral parametrium. So when I say lateral parametrium, it includes pelvic wall. Okay, touching the pelvic wall, Okay, so finally we have stage 4. Okay, so what is stage 4? Stage 4, again we have 4A and 4B. Okay, here we have 4A and 4B. Right. Okay, so 4A is involvement of bladder and bowel mucosa. Okay, 4A is involvement of, I'm sorry, I'm just missing one point here. That is, 3C. Okay, stage 3C. Okay, and in 3C we have C1 and C2. C1 is involvement of pelvic node and C2 is involvement of parametrial node. Okay, C1 is involvement of pelvic node and C2 is involvement of para-aortic node. Okay, para-aortic node. Okay, so coming to stage 4. Stage 4 is easy. Okay, under stage 4 we have 4A and 4B. Okay, 4A is involvement of the bladder and bowel mucosa. Bladder and bowel mucosa. Okay, 4B is distant met. Okay, distant mid. Okay, so this is about staging of which we have 1, A1 mm, A2 is 3 to 5 mm, and A1 is otherwise called as microinvasive. Okay, 1B is macroscopic, inside which we have B1, B2, B3, less than 2 centimeter is B1, and then 4 is B3. Okay, stage 2 we have A and B, upper vagina is A, medial parametrium is B. Stage 3 we have ABC, lower vaginal involvement is stage 3A, lateral parametrium is 3B, and node is 3C. Okay, now let me mark the important MCQ point only. Important MCQ point only. Guys, listen. The first MCQ area is this. What is microinvasive? What is microinvasive? 1A1 is microinvasive. Okay, 1A1 is microinvasive. Guys, next, what all stages are there where the patient measures more than 4 centimeter? That again is the next MCQ. 1B3 measures more than 4 centimeter, and 2A2 measures more than 4 centimeter. There are two stages. There are two stages measuring more than 4 centimeter. What are they? 1B3 and 2A2. Okay, this one and this one measures more than 4 centimeter. Okay. Next important MCQ, what where does pelvic node come and where does para-aortic node come? Pelvic node is C1, para-aortic node is C2. Okay, so these are the important MCQ areas here in the staging of cancer cervix. 4 points. What is microinvasive? 1A1. What all lesions measure more than 4 centimeter? 1B3 and 2A2. Okay, pelvic node is stage 3C1, para-aortic is 3C2. Okay, so this is about the staging of cancer cervix. Staging of cancer cervix. Okay, to finish this session, I will also tell you some points on the staging of CA endometrium, ovary and vulva. You can learn by yourself. Okay, so endometrium is very simple. Staging of endometrial cancer. Okay, staging of CA endometrium. Here again we have 4 stages. Here again we have 4 stages. Okay, stage 1. Stage 1 is divided into 1A and 1B. Okay, what is stage 1A? Less than 50% of myometrial involvement in CA endometrium. Stage 1 is limited to uterus. Okay, limited to uterus, and in turn in this less than 50% of myometrial involvement is 1A, and more than 50% of myometrial involvement is 1B. Okay, so less than 50% of myometrial involvement is 1A, more than 50% of myometrial involvement is 1B. Okay, coming to stage 2. Okay, now under stage 2, all FMGE aspirants, what I want you to remember is only one point. Stage 2 of endometrial cancer is involvement of the cervix. Okay, stage 2 is cervical involvement. So not the cervical gland but the cervical stroma. Okay, not the cervical gland but the cervical stroma. Okay, what is stage 3 here? Very simple. This again is simple. Okay, stage 3 has 3A, 3B and 3C. Okay, 3A is involvement of serosa. Serosa means peritoneal covering of the uterus. Okay, serosa and adnexa. Adnexa means ovaries. Okay, ovaries and ligaments. Okay, serosa and the adnexa. Okay, stage 3B is involvement of the vagina and the parametrium. Okay, vagina and the parametrium. Okay, so ligaments come under parametrium, sorry. Okay, so serosa and adnexa is stage 3A, vagina and parametrial involvement is 3B. Okay, now the unique point about the endometrial cancer, I mean the most favorable point here is that from here onwards 3C1, 3C2, 4A and 4B of endometrial cancer are the same as cervical cancer. So that's really good thing. Yes. So C2 and C2. Okay, 3C1 is involvement of pelvic node, C2 is involvement of para-aortic node, 4A is bladder and bowel mucosal involvement, 4B is distant met. 4B is distant met. So it is just simple. Okay. So this is staging of okay. So again, I'll tell you the important MCQ points here. Okay, guys, remember this is important. This is important not because we see more patients in this stage, but only because this is similar to the staging part of cancer cervix. This is similar to cancer cervix. 3C1 is pelvic, 3C2 is para-aortic, 4A is bladder bowel, and 4B is distant met. This is similar. Okay. The second important area is stage 2, which is the involvement of cervical stroma and not the cervical mucosa. If cervical mucosa is involved, it is not stage 2. It can be stage 1 also. If cervical stroma is involved, it is stage 2. These are the two important areas under the staging part of endometrial cancer. Okay. So hope you will read ovarian cancer and vulval cancer, staging part of ovarian and vulval cancer by yourself. Okay. So because we are running out of time. Someone's asking something, will there be any second session? I haven't planned for a second section, doctor, but we'll try my best. Okay. If time permits, we will have a second session. Okay. So this is it. Thank you guys for participating here. Thank you for interacting with me, especially Prashant, Aryan, Hechin, and Avinash, Dana. So hope this session was useful for you all. Meet you all in another good session. Okay. Subscribe to DocTutorials for more videos like this. Thank you.